left, and we'll try to see how fast we could run because of our evaluators who needs to travel. So we will be starting, apologies colleagues on the IT, there will be slight readjustment to the slide deck based on who is available for now. So we will be starting with health service provision this morning. That's the only team complete for now. And we will be glad to welcome to the podium the team members for these technical areas, the areas we're going to mention, but let's start with health service provision. So to start, we have Dr. Joshua Ofoli from the World Health Organization. Please, if you're around, can you please join the high table? Closely to be supported by Dr. Adetunji Adedokun for ICAP. Please join the high table, sir. Representing Georgetown University, we have Dr. Winifred Uponu. Dr. Winifred, do you mind to join? And leading this technical area and to also present for this section is from the federal representative of the Federal Ministry of Health, Dr. Dakun Benji. Dr. Dakun, do you have the floor, please? A round of applause for them, please. And from the evaluator side, we'll be glad to have the team on the high table so we could take the introduction. Thank you very much, Doc. So again, permit me to announce, for those who possibly have not been part of the conversation before now, there will be time allotted for presentation and the time for the evaluators to provide their feedback and discussions. A time keeper is available to give us signals, so please let's pay attention, the presenters, so that we could have very smooth engagement. Outside. So we have a slight modification to the table today. So you have your mic. All right. So we're glad to have the team introduce themselves again quickly. Then we go on to the business of the day. All right, Dr. Dakum, we have you have the floor, okay. And the time starts now. Over to you, please. Okay. Or shortly, if you don't mind, if we can introduce again the team lead and the co-evaluators for this section. Over to you, sir.
Thank you, Mr. Coordinator. Good morning, everybody. This is our third day and our final day for the discussions. Tomorrow we will have two days.
Good morning, colleagues. My name is Noor Alam. I'm from Australia, and I'll be leading this technical discussion on the health services provision. Thank you.
Thank you very much, the evaluators. So Dr. Dakum, you have 12 minutes for your presentation and the time starts. Thank you.
Thank you, MC. The team lead and facilitators, distinguished participants, good morning all. So I will be presenting the one of the newest addition of the technical areas, which is health services provision. Health is on the concurrent list in the Nigerian Constitution, and it is administered at all levels of governance, that is at the local government level, state, and the federal government. And the Nigerian health system is three-tiered, consisting of primary healthcare, secondary healthcare, and tertiary healthcare. The government of Nigeria, the federal government is responsible for tertiary healthcare, and the state, the subnational, are responsible for secondary healthcare, and then the local governments are also responsible for primary healthcare. But since it is on the concurrent list, then you find some interplay of subnational government venturing into tertiary healthcare services, provision of tertiary healthcare services. And that's why you find states having teaching hospitals, having specialist hospitals, and you also find the federal government, which has the responsibility for tertiary care, also venturing into primary health care with the introduction of the National Primary Healthcare Development Agency. So there is a well-defined package of essential service provision, which has been categorized by the level of health care. So there is a standard defined package that is expected to be gotten in a primary health care, secondary health care, and tertiary health facility. So assessment of health services is the responsibility of governments at all levels. So both the local government, states, and the federal government. And some of these reports that I've generated use as evidence to inform policy reviews and, of course, to sustain efforts towards strengthening the health system. The Nigerian government has also adopted the district health information system as the major tool for data collection and as the national reporting system for all health data, including service utilization, across all sectors and regions using disaggregated variables. This must be emphasized that the DHIS tool, data collection tool, is responsible for population data. But when you want to look at health services provision data, where you want to look at patient-level data, you find some pockets of data collection platforms disparate in some systems and in some hospitals that are different from this. But they have to integrate and report to the DHIS2 as mandated by the Constitution of the country. So as part of emergency preparedness and response effort, the Federal Ministry of Health has designated treatment centers and isolation centers for health emergencies. And these treatment centers and isolation centers has multidisciplinary capacities and virus capacities at different facilities in the country. And to strengthen healthcare delivery at every system, the country also has a two-way referral system that is faced with a lot of challenges and is also weakened when it comes to implementation. As we speak, there is no national guidance document on continuity of essential health services during emergencies. So attempts have been made by different sectors to develop some of these documents, but there's no overarching national document that will guide continuity of essential services during emergencies in the country. And assessment of health facilities are conducted for different reasons by some government agencies to assess facility and health systems at intervals, but these are not properly coordinated. For instance, in the Federal Ministry of Health, the Department of Hospital Services, which has the statutory responsibility of oversighting all the federal tertiary health institutions in the country, has the National Tertiary Hospital Standard Committee. And the mandate of that committee is to conduct facility assessment to ensure standards are maintained in those hospitals and also to categorize or accreditate those facilities. That is one form of assessment that is done. I'm also aware National Primary Health Care 2 conducts some assessments, but as we speak, there is no overarching coordination to say the responsibility of facility assessment lies with a particular tier of government. And strategic tools for assessing risks or vulnerability are also yet to be developed for defining priority health events. This is not to say some government ministries and agencies do not have some form of tools that they use to assess risks and vulnerability. There is also non-availability of a centralized national clinical data management system to process and streamline data flow from public and private health facilities managing priority health events in respect to health services provision. So these are some institutions, ministries and departments and agencies of government that are responsible for provisions of health services. So the Federal Ministry of Health, you have the Health Planning, Research and Statistics, the flagship program of the country, the National Emergency Management Services and Ambulance System. You find the paramilitary, the military, talking about the police and prison service, and also you looked at the aviation sector and others. We have international partners led by the World Health Organization, also deeply involved in provision of health services and providing technical support to this technical area. We also have the Columbia University, the Georgetown University, FHI 360, Clinton Health Access Initiative, and a lot more of other non-governmental partners. So the scoring for case management, we looking at the scoring system and looking at where the country is, we scored 1, which is actually low, and there are justification for scoring 1. Some of the justification are there are current scope of case management program that have been designed, restricted to management of some priority diseases against priority health events. We have some guidelines that have been developed and disseminated for some priority diseases, while others are being developed and finalized. There is actually no timeline attached to this. And therefore, in some instances, there's no sense of urgency in getting some of these guidelines developed. And compliance with the guidelines is also another issue. Its implementation in subnational government also another problem. So aside COVID-19 treatment guideline, which is an interim treatment guideline, there is actually no structure in place for routine evaluation and review update of those guidelines. And suboptimal implementation of case management priority health events at the intermediate level subnational government because of inadequate resources such as infrastructure, the staffing, and funding to procure commodity supplies, medicines, and consumables. The major strength of the case management pillar is that the ability of the pillar to develop some guidelines for some priority diseases and the ability to also disseminate and implement this at all levels. This has been done and implemented with the COVID-19 as a case. Protocols for some priority diseases have also been developed for cholera, Lassa fever, monkeypox, diphtheria, and others. A strategic coordination for implementation is in place for some of the priority diseases. But the best practice that have emerged from the case management pillar is the institution of the community of practice, which is a peer review platform where all case managers in the country are aggregated and put under one platform to peer learn within themselves, and subject matter experts are invited from different parts of the world to share their own experiences of how some of these priority diseases are being managed. And with that, we've also been able to adopt and in the process of implementing the pilot fellowship program that has been done to strengthen and expertise in case management of priority diseases like the viral hemorrhagic fevers. So by next week, the country will be piloting the Lassa fever clinical management fellowship for case managers. So the areas that will require strengthening will involve a frequent review of these guidelines, given the increasing findings on the management of cases to reflect the current realities on the management of priority diseases, instituting a monitoring, evaluation, accountability, and learning framework for the implementations of these guidelines and protocols. And there is a need to do a stakeholders engagement to ensure resources are mobilized for case management of priority events. and also to improve the clinical management, data management systems for evidence-based guideline development. The challenges that have emerged are guidelines are not being updated as they are supposed to. Protocols are not implemented with strict compliance and fidelity. There is also the issue of suboptimal capacity of case managers to collect, analyze, and use clinical data to inform clinical decision-making processes in the clinics or in the hospitals, and then scientific reviews of these guidelines that will generate evidence to improve clinical management of patients. There's also non-availability of clinical data platform to collect and store data. There is inadequate resources for scaling up of trainings to operationalize case management guidelines. So the priority areas for action, we believe, is to develop a case management treatment compendium of priority health events. The country has done this because we have treatment guidelines that have been distributed and well disseminated in clinics and to clinicians. We also want that recommend a 5-year periodic review or as necessary of case management guidelines. There is a need to institute and develop a strong and robust monitoring, evaluation, accountability, and learning framework for the implementations of already developed guidelines and protocols. The country, as we speak, has no emergency preparedness and response plan, even though some exist, multi-hazard for different agencies of government. So there's a need to develop one for the country, that is the National Emergency Preparedness and Response Plan for the country. So we have some of these supporting documents that we will submit as reference. For utilizations of services, the scoring, we scored the country 2, and in level 2, the outpatient visit ranges between 1 and 2 visits per year in both rural and urban areas. Utilizations of health services, the areas of strength are that the country has availability of a very well-functioning reporting system. There is already a collection of trained personnel for use of district health system 2 reporting system. There is a regular reporting mechanism that the country has adopted for reporting health data. There is also the available legislation guiding health services provision. And some of these are backed by the National Health Act of 2014, which backed the data management system and empowers agencies of government to manage and store data. So the country has functional legislation for data management and storage. The areas that will need to require strengthening are there should be a health worker incentive scheme at the national and sub-national level for retention of health workers within the health system.
Sorry, Dr. Dakom, you may have to wrap up.
Okay.
Thank you.
Some of the challenges that we've seen is the so-called brain drain, attrition of skilled health workforce, overstretched health workers, and medical tourism. So we believe that there is a need to develop and fund and monitor a health worker incentive scheme at the national and sub-national level. There's also a need to strengthen community engagement and participation for the people to take ownership of the health system. Priority and supporting documents are the DHIS2 monthly data and service utilization report from the Department of Health Planning, Research and Statistics. For continuity of health services, we rank the country at level 2, and these are the strength of the country, the continuity of essential services, availability of a nationally defined package for essential health services, availability of joint crisis management document, and development and dissemination of advisories on continuity of essential health services during emergencies. The best practices are collaboration between health and other sectors, which is a multisectoral platform, strong coordination for emergency preparedness
All right.
and response.
You may need to stop.
The challenges,
No, we
please.
wouldn't be able to take these apologies. We are done with your time. You spent extra 5 minutes.
Okay, fine.
If you could just 1 minute to wrap up.
Oh, fine. So we believe that the areas that will need strengthening are plans following simulation exercises and post-event reviews, which would also inform improvement. So we want to develop a governance, accountability, and coordination framework for the continuity of essential health services during emergencies, and development of a monitoring, evaluation, action, and learning framework for implementation of post-event improvement plans. So these are some of the supporting documents that we submitted as reference document. These are recommendations, and then thank you for listening.
Thank you very much, Dr. Dakum. So over to the evaluators now. Thank you.
Thank you very much, the national team, for presenting and covering these important technical areas. This technical area have got three very important sub-indicators. The case management, essential, the utilization of health services, and the continuity of the emergency services during the national emergencies. So, if we start with the case management part of your presentation, you have got some good areas that you have developed or working on the continuing basis. We have got some guidelines at some level. I believe it's mainly national, but maybe some national as well, although you didn't specify. Some protocols are available, but there is a limited, very limited capacities in the case management, particularly when it comes to the multidisciplinary specialty services in hospital and health centers, and particularly during the emergencies. Case management, clinical case management is essentially a very important area from the service delivery perspective. And when it comes to the emergencies, like COVID, for example, in this situation, you will be inundated with the service difficulties. So from that perspective, you definitely need a very good set of guidelines, SOPs, and also the trained manpower. Yes. So you have now identified some priorities areas where you need support. So if I go to the area that needs strengthening, can you please go to the slides, 3.1, areas that need strengthening. Yep. So you have identified the frequent review of guidelines, given increasing findings of management of cases. In the first place, we have to have the guidelines in place. Yeah? And that guidelines is a specialty-based guideline, because one guideline is not necessary for one particular disease, but not necessarily meeting the need for other areas. Yeah? So you need the overarching guideline, and then based on that guideline, you need the strategy to implement, and also the SOPs at the lower level. So the personnel involved in these service delivery case management, they are skilled and available to provide that service. Yeah? Not just the guideline. You should have a guideline. Plus, what is more important is the trained personnel, those who are aware of the case management responsibilities. So the SOPs and the training, that should go hand in hand. Yeah? So you have rightly identified, but I think I would suggest to add also the training for the personnel and the standard operating procedures at the specialty level in each area. Yeah? So you have mentioned also the monitoring, evaluation, accountability. That is very important. So it's a meal. So yes, I will stop here right now for this one, for the case management. I think these are the key areas that you identified. I would invite any comment from the podium, from my co-lead. Anything you want to add? Case management first. Thank you very much, Jeffrey. So I would ask if any of my JE colleagues want to add anything, any comment?
All right. External evaluators, do we have any comment on the presentation?
No? Okay. Then I think if we look into the priorities area of action, yeah, I think I would need to go to the, okay. From the audience,
Yeah,
for the case management indicators, is there any comment or you want to make any suggestions or anything?
Yeah, we have one already. Go ahead, ma'am.
Good morning, everyone. My comment is not really strictly on case management. I just wanted to correct an impression that there's no country emergency preparedness and response plan. We do have a country emergency preparedness and response plan, and we have done a country strategic risk assessment spearheaded by WHO Afro, which every MDA, including Ministry of Health, was part of that exercise. And the preparedness and response plan has been signed by every MDA, including Ministry of Health. So it's just to correct that impression. We do have those plans. Thank you.
Thank you. Any other comments? Okay, at the back.
Okay.
Thank you very much, Dr. Daku, for that presentation. Mine is just a suggestion on how you can expand your community of practice, because a couple of colleagues here that are leading case management pillar of some priority diseases, we are saying they are not part of that community of practice. So see how you could expand that network. Thank you.
If no other comment, we'll move to the next.
Okay.
Yeah. No?
Any other comment? None for now.
No.
Maybe we move on. Thank you.
All
Sorry.
right. So for the case management, so you self-score yourself as level 1. So you believe that based on the strength and also the areas of support that you need, you identified. So this is a fair score, in your opinion?
Realistic score.
Okay. So what about our colleagues from the external evaluators? All good? Agree? Yes, I think we all agree on that. This is a very rational, the scoring that you identify with. So thank you.
Okay, thank you.
So we move to the next indicator, which is the R3.2. If we go straight to the strength slide. Yes. So we have got some strength on the availability of functioning, especially the reporting system. I wonder how this is consistent, whether this is consistent with the case management, because I think we have a lacking of the reporting system in the case management aspects. Yeah. But here, you mentioned the availability of functioning reporting system. So when you say functioning reporting system, so is it running a good, sufficient in terms of the frequency and the quality of reporting, and is it a defined reporting system available for the utilization of health services? Okay. Yes, at the national level. Yes?
Yes.
Okay.
The country has a reporting mechanism that is for the DHIS2, where data flows from the facilities, it gets to the local government, and from the local government moves to the state, and then from the state is aggregated at the national level. That is for health services. But when you're talking about priority diseases, like when you are in an emergency, like for COVID, there is a different reporting platform that the country has adopted, use of SOMAS. And this is supposed to provide like a real-time reporting flow. And designated treatment centers where case managers are located, I suppose, by treating these patients and then inputting those data, the flow directly to the national dashboard where those are taken and informed decisions are made. But we must make a distinction between these two. That for DHIS2 is mainly a population data. But for case management, the case manager is usually interested in looking at patient as an individual. And in doing that, he is interested in treating every patient as a case and not just looking at a collective sum where you just look at patient to determine prevalence or incidences or not. But what he wants to do is whether his own drug are working, whether patients are reacting to some form of the treatment, want to determine the length of stay in relation to the disease pattern, whether it's moderate, mild, and all that. So these are some of the strengths that the country has been able to adopt. And so we feel that this should go for the strength.
Okay, I think this should reflect also what you have and what you are lacking. So if we move to the next slide, which is the areas that needs support or needs improvement. Okay, now we have got here the frequent review of guidelines. So, okay, so here I think there is a little bit of change of what we have got here. So you have identified the areas of health worker incentive scheme at the national and subnational level. But I think the incentive scheme comes after, once you have got the established system, which is the healthcare services utilization mechanism, well established. Then you assess and see what proportion of population and what is the characteristics they are not utilizing the health services and what is the reason. Then the incentive curve next as a strategy, right, to increase the intake of utilization. So I would suggest this may be one of the area as a priority, but I think the first thing first is the platform, the structure, the guidelines, yeah? That should be first defined, and then these come as a strategy to increase the utilization through incentive program. So, any comment from our colleagues? Yes.
Okay, fine. Thank you. I would make an attempt, that is if I actually get what you are saying. The country has actually defined and adopted some mechanisms to make healthcare available to the 200 million Nigerians. And one of those platforms is the Basic Healthcare Provision Fund, which has about 3 gateways. Those gateways are actually designed on the principles of demand and supply. So to create demand, the National Health Insurance Authority is empowered to ensure that people are insured and they are able to access healthcare, not from payment out of pocket, and not waiting because they can afford before they access healthcare. But with that, it is meant to open up access to the 200 million Nigerians. And the country also took cognizance of the fact that not all Nigerians are the same. And so some are categorized. And may be given exemptions, like the vulnerables, the elderly, the under fives, pregnant women, and others. So that is meant to open up the access for healthcare. When you now look at to the supply side, looked at mainly services. And this is done to institutionalize and strengthen the National Primary Healthcare Development Agency through healthcare centers by ensuring, because healthcare centers are the closest to the people. And that is the center that is the grassroots center. And if health services are improved at that level, then access through insurance and other means, contributory, community insurance, and what have you, will now ensure that is supplied on that. Another key component of that framework is the emergency gateway. That emergency gateway is designed such that emergency health services are made available to people who require, those who are in emergencies, without paying a dime. So you find a gunshot injury patient, a road traffic accident victim, a patient that has been poisoned, be able to access healthcare anywhere without paying a dime. So until you are out of the emergency situation, then a matrix will be used to assess whether you have the capacity to pay or not. If you do not have the capacity to pay, the country waves it aside for you. So I believe that these are strong attempts of the country to do this. And then aside these governmental roles, the country also has the private sector driven process in the provision of health services, even though that is also to the reach of those who can afford.
Okay, I think thanks very much for these clarifications. I think still you have got a lot of challenges you have identified already, and these are all very valid, legitimate, the challenges that you identified. So if we're moving forward, taking into consideration all these, can we go to the scoring that you identified? The scoring for 3.2, R3.2. So you identified level 2. I think this is, in my opinion, is very fair, and I'll ask the opinion of our colleagues for this, given all these challenges. What do you reckon? Is 2, yeah, you agree? So,
Thank you.
our colleagues, external evaluator, do you concur this? Yeah. Okay, we have a concurrence from our team as well. From the floor.
Are there other comments?
No comment from the floor? Okay. Now I would offer the country team whether you agree this our suggestion.
Okay.
Yeah?
We'll take a look at it again.
Score 1.
Yes.
Down to score 1, yeah?
3.2 goes back to 1.
So that you have got enough room for development, because this is very complex. And
It's true.
yeah. Point 3.2 is it 1, right?
Yes.
Okay, great. So moving forward, the next one, 3.3.
So, sorry, apologies. I'm not sure they got that very clearly. 3.1 is 1.
1. 3.
Now 3.2.
2 is also 1.
So they are taking this back to 1.
So we propose the
Uh-huh.
score
back to 1.
for 3.2 should be 1 instead of 2.
No, wait.
And do you agree to that?
So we were able to have some forms of evidence which might not be speaking to the generality of Nigerians. But we've taken a look at the outpatient attendance data from the health planning, research, and statistics. But we will take a look at this again and then see whether it's consistent with your suggestion, then we'll revert back.
So you want the side room discussion and then come back?
Yes, after we'll now decide and then come back.
Side room.
So whether we'll be consistent with going to 1.
So after this session, we'll go to the side room, we discuss on this and then come back. Okay, the next one. So please moving forward to the next. The priority action for 3.3, R3.3. So if you go straight to the priority action areas. Yes. 3.3. Yes. Going. All right. So you identify a lot of difficulties also for these indicators for maintaining the continuity of essential services during an emergency. During COVID, that was a burning example we have seen. In many cases, people, were denied access to the healthcare system. Those who have other difficulties, non-COVID, not COVID, at the height of the crisis over the first 2 years, at least. Many people have died of other chronic conditions like, the chronic kidney diseases that they could not even do the kidney dialysis, for example, which was necessary. So given these scenarios, I mean, the state, the nation should have a very clear definition and also the mechanism, how they will ensure the continuity of other critical health services, not just the disease in question at the time of crisis. Now, given, again, going back to the point of the country's population, the sheer size of the demand of healthcare system for the 200 plus million population, we need to have a very clear strategy and the mechanism how the state would run and the continuity, how the state will ensure the continuity of the essential health services. And you have identified many areas of the lacking. And moving forward, the strengthening, again, this is also linked to the previous indicators. So if we go to the scoring next, can we go to the scoring page, please? We need to finish. Level 2. This is also my concern, whether it is fair to score 2, because again, the continuity of health service, for that to ensure, you have to have not only the commitment from the government, but as well as the facilities and also the trained manpower and many other opportunities available. And as previously we mentioned, and we inclined to give 1 because of the limited or no capacities. And this is no different. And in my opinion, I would go for score 1. What is your response?
Okay.
Yes. Yeah. My colleagues, yes. You want to add any? Sorry.
Okay, so we have to.
So I go back to you, lead. I can do the co-lead.
Okay. Yes. Out of our input from our team, external team, please. Any comment from? Yes, I think I can.
So we have the mic here.
Yes.
Thank you so much. I am also concurring with Geoffrey for level 2 because they did indicate they have packages for the different levels of care for primary, secondary, and tertiary. But what is unavailable is the plans and guidelines being for essential continuity in emergencies, not yet finalized or developed. So I concur with him.
You want to make some? You want to make a comment?
Any other input?
Is that right?
Okay. I respect the opinion showed by my team members. Yes, there is a logic for that, and I was linking this particular indicator with the previous indicators as well, because I did not consider this one in isolation, because these are all linked. So that was the basis of my suggestion, but I go for 2 in respect of my colleagues' opinion and also the national team. So now, thank you.
Thank you so much. I think you are in consensus. This is for because you proposed it yourself. So this means that I kindly ask the Nigerian team on health services provision and the external team, lead and co-lead, somewhere in the day to go to a site visit to try to get consensus on the second indicator for the scoring, and also to identify priorities. Because of time, we have no time for this now. So when you are coming back to the plenary, I would like to hear from you a set of priorities and whether you have or not consensus on score indicators. It is a very important topic. It is about healthcare facilities for your people, and I think it's good that we took some more time for this. But now we have to go to other important topics. So I close this technical area, not finally, because you have to come back to the family. And I thank you all, the Nigerian team and the external team, very much. Thank you.
Thank you all.
Thank you very much. The theme, I think it's fine now to appreciate the technical areas that goes back to their seat. Thank you very much, the Health Service Provision theme for the injustice today. So you may want to proceed to the side room now and finalize. All right. Dr. Hank, I think you may want to discuss the lab conclusions now, if you don't mind. I know. So do we have the lab team in the house? No, we are taking conclusion of the resolution yesterday from the lab team. We need to just get their agreement. Okay, so we have the lab representative, then from the evaluators. So you could address us on what your conclusions are. Team lead, sir.
Okay. Yesterday, after a careful deliberation on D13, which we had scored ourselves for, we had a frank discussion, and at the end, we decided we're going to go with what was suggested by the external assessors, which was a 3.
So it turned out that the team agreed that the national laboratory system is not national reference laboratory. It's a big animal. It has different layers or different tiers. It serves different sectors, all who must be satisfied with the services. as it were, it turned out that the human health laboratory services were well defined and doing much better than the other sectors, which is the animal health as well as environmental health. So we agreed to have the score at 3, sorry. Thank you.
All right, thank you very much, the National Laboratory Systems Technical Area. Okay. So moving on, we now have the next technical area for presentation, and that will be the legal instruments. And for this team, we have the lead presenter for this section will be Barrister Safia Musa from the Nigeria Center for Disease Control. Round of applause for her, please. She will be heavily supported by colleagues from Ministry of Justice, Roviano Dixon Hamagada. A round of applause for him, please, as he joins her on the podium. Also, from Resolve to Save Life, we have Barrister Hemem Hudo. Barrister Hemem, thank you very much for joining. And also from the Nigeria Center for Disease Control, we have Amira Habubakar. Amira, the floor is yours. So we have the Nigeria team, and for the external evaluators, you have the floor to introduce the team, and we'll take it up from there.
Success. Oh, thank you. Good morning. Good morning. We haven't met formally.
No, my name's Henk.
Oh, okay, nice.
And I'm the lead of the external team.
Yes, yes, I learned that. Nice to meet you.
So, good morning.
Where is William?
Our team lead is Sarah, so she will contact you after.
Yes, we've met Sarah. Good morning, ladies and gentlemen, external evaluators. Our presentation is on legal instruments.
Just a second. There is a list modification. She will be joined from the Ministry of Justice by, I think it's barrister for everybody in the ministry anyway. Barrister Bimbola Hajile. A round of applause for her, please. Thank you. Please, you have the floor, ma'am.
Recognizing the role of law as an efficient and effective tool to influence public health outcomes, Nigeria has, since the last JEE, strengthened its public health security legal framework. We have done this by enacting and formulating various laws on prevention and control of diseases, such as the Nigeria Center for Disease Control Act, which not only creates NCDC as the country's foremost public health institute with the mandate on control and prevention of communicable diseases, it also vested in Nigeria Center for Disease Control the mandate for the implementation and coordination of IHR activities in Nigeria. We also have the Animal Disease Control Act and the Public Health Emergency Bill, which has passed the lawmaking process and is currently awaiting assent by Mr. President. Stemming from all these laws, generally, health security coordination and funding has been enhanced. We have improved funding for public health security also. We have introduced the National Guideline for Integrated Disease Surveillance and Response. This was introduced in 2019 at the National Council of Health. We've conducted a comprehensive assessment. I would want to say here that public health issues are governed by state laws and federal laws. So we have conducted a comprehensive assessment of all our federal laws in 2020 on disease surveillance, detection, response, port health, quarantine services, and food safety. The identified gaps from these assessments led to the amendment of the Nigeria Center for Disease Control Act. This amendment process is currently with the lawmakers as of the last session of the lawmakers, which ended, is it 20, when did it end? Last month. Okay, it ended a couple of months ago. The lawmaking process on the amendment of the Nigeria Center for Disease Control Act has already been concluded. We're just waiting for transmission on to the presidency. Also, from these identified gaps, we've also drafted the Animal Control Bill Act and also to prevent the spread of infectious and zoonotic diseases. These are the legal instruments we've worked on. The amendment of the NCDC Act, which guarantees increased funding for public health security by having a dedicated fund, a health preparedness fund embedded in the new amendment, amongst other things. The Public Health Emergency Bill, which is a bill dedicated for public health emergencies and outbreaks. This also has another funding line embedded for health emergencies. We have the Port Health Service Bill, which repeals the old quarantine laws. This also makes provision for quarantine and protection of, it repeals the old laws and makes provision for the prevention, introduction, and spread of infectious diseases in the country. Additionally, we have conducted an assessment, just like I mentioned earlier. At the state level, work is ongoing. We have conducted assessment of state health laws, and presently we've concluded work on 7 states, out of which 5 states have already moved, enacted, and passed their own public health laws. So these are our strengths. We have a very good relationship with the lawmakers, a cordial and positive working relationship for the review and reform of public health laws. All stakeholders demonstrate high-level commitment to fully implement the IHR core capacities in Nigeria. Public health MDAs have, by the way they are constituted, legal departments to support the legal implementation of IHR. Best practices. Health-related reforms are regularly included in periodic legislative agendas of the National Assembly. There is an existence of Law Reform Commission of Nigeria established to oversee and promote the reform of laws, including health laws in Nigeria. Areas that need strengthening. Establish a legal framework, legislative or administrative, for legal surveillance across MDAs, ensuring periodic reviews of all legal instruments in the country. Develop a dedicated budget line for the development and enhancement of legal instruments, thereby facilitating efficient legal reforms and updates. Challenges. Lack of funding for legal activities to strengthen public health laws. absence of capacity building for legal officers in public health law. Law by its very nature is dynamic, more so public health law. With the recent happenings in the field of public health law, we are constrained by not having training on capacity to handle these new and emerging issues that come up. Scarcity of funding impedes the timely review for updating of obsolete laws related to public health law, and lack of advocacy after the review of these laws is also a serious issue. Bureaucratic arrangement in the lawmaking process, which delays passage of bill. If you recall, I mentioned the amendment to the NCDC Act has undergone the final process of lawmaking. Ideally, this would have been passed before the last civilian administration went out. But because of this bureaucratic arrangement, we find out the law is still with the lawmakers. Scoring. The country has conducted legal mapping of relevant laws, relevant legal instruments for IHR implementation at the national and intermediate levels and are documented. So we've scored ourselves 2 on this. Recall at the last JEE, our score was on level 1. Rationale for the score. The country has conducted a legal mapping and assessment of the legal instruments at the national level and at state levels. That 7 states have been done. And the rollout for the remaining states is starting in September. New laws were drafted from the recommendations of the assessments conducted. The NCDC Bill Amendment of 2022, the Public Health Emergency Bill, the National Health Act Amendment, and the Quarantine Bill, which establishes the port services. The reviewed legal instruments make provision for legal authorities for health emergency declaration, preparedness, operational readiness, and responding planning. 4 states at the intermediate level have passed their public health security bills. I'm waiting for respective governor's accent. On gender equality and equity. On this, the score on this is 1. This is because this is a new area. How do you move? Oh, okay. Yeah. So on gender equity and equality in health emergencies, no systematic assessment of gender gaps in any of the IHR capacities has been conducted. So on this, we score 1. Rationale for the score, the indicator P12 is newly introduced component in JEE 3.0. Currently, there is no funding allocated to activities under this indicator. Priority areas of action. To conduct subnational legal assessment of health laws at all the outstanding 30 states of the Federation. Conduct comprehensive gender assessment of legal instruments to identify and address gender-related considerations. Establish a framework, legislative or administrative, for legal surveillance across MDAs, ensuring periodic reviews of all legal instruments in the country. Prioritize capacity building initiatives for legal officers in the field of public health law. prioritize securing adequate funding for legal activities related to public health laws, such as creating a dedicated budget line to support legal surveillance, periodic reviews and reforms, ensuring the effective implementation of public health legislation. These are our supporting documents: the NCDC Act of 2018, Ports Health Services Bill, Animal Disease Control Act, Public Health Emergency Bill, National Health Act Amendment, NCDC Act Amendment, IHR implementation in Nigerian law, mapping of legal authorities, and analysis of legislation at the federal level. Legal assessment of 7 states conducted so far. And these are a list of our team members who have been earlier introduced. Although, unfortunately, Ministry of Health could not be here with us today. Likewise, Minister of Agriculture. Thank you very much.
Thank you very much. The legal instrument and technical area. Over to the evaluators, please.
Sorry, I kind of skipped our priority actions. Very important. I need to go back to that. Yes. So these are our... I'm not on. Oh, okay. So these are our priority actions. We intend to conduct subnational legal assessment of health laws at the outstanding 30 states of the Federation. Conduct a comprehensive gender assessment of legal instruments to identify and address gender-related considerations. Establish a framework, legislative or administrative, for legal surveillance across MDAs, ensuring periodic reviews of all legal instruments in the country. Prioritize capacity building initiative for legal officers in the field of public health law. Very important. Prioritizing securing adequate funding for legal activities related to public health laws, such as creating a dedicated budget line to support legal surveillance, periodic reviews and reforms, ensuring the effective implementation of public health legislation. Thank you.
Thank you so much. I really appreciate the work from the country team on this, and I want to congratulate you on absolutely enormous accomplishments with respect to all of these bills. I know that you did not emphasize it, but that we also have several pending bills that are the result of your hard work in this area. So thank you for the presentation. I have a couple of comments, and then we could pass to just discuss the priority areas. First, I want to acknowledge the innovation and the importance of the work at the subnational level that you're beginning to explore now. Recognizing that 5 states have already passed these public health laws, I wonder if I can ask about how you would think about stepping up this work. I know that in terms of next steps, you mentioned, how can we roll this out at the subnational level? How can we make sure that these assessments are carried out at the subnational level? And so I'm interested in just hearing your thoughts and the team's thoughts about how that can be done. What are the concrete actions that we could take to help you there?
Okay, thank you for that question. So for the subnational assessment for the remaining 30 states, we already have a rollout plan, and we intend to do that by September. We're working with our partner, Resolve to Save Lives, who's supporting that, and is the one supporting us. Thank you. So do you want to?
Well, yeah, thank you very much. So, well, the plans towards the subnational, especially as we have been able to see the success gained in the first pilot states. This assessment was done in conjunction with other health assessment exercise broadly, but what we have seen is that states have been very willing to push through this assessment. So last year, which I think was not mentioned, the NCDC team has already progressed in developing a tool for subnational assessment and also trained the legal officers of the 36 states in using that tool. So we are hoping that before the end of the third quarter of this year, we would have the entire state of Nigeria assessed at the public health laws level and then recommendations provided. And also just to point out, in terms of the new area which was included in the JE 3.0, I think under the leadership of Barrister Safia, we have been able to adapt the WHO tool that was developed in 2011 to a Nigerian-specific tool for gender considerations of our legal instruments, and that is also part of the assessment that will be done in September. And we believe that if those assessments are conducted in September, Nigeria should be moving from where it is in 2 to 3, 4 and 3 respectively in the different indicators. Thank you.
Yes, just like he mentioned, the process had started, but because of the onset of election activities, so we had to step down on it because it involved bringing in colleagues from the 36 states. And because of the sometime happenings during elections, we didn't want to have lawyers traveling to and through Abuja. We had already done the first set of training, but we had to step down till after the election. Actually, to address this and to prevent the happening of such, that is why we're helping states develop new public health laws to align with federal laws. So the new laws being developed in these 5 states that have been passed have aligned with what we have at the federal level. And we intend to continue this work with other states. So there is no possibility of contradiction of laws, conflict of laws, when it comes to the new public health laws as it is. Thank you. You want to add something?
We should also add that what has gone on was that NCDC has developed what we call a model public health laws for subnational. So these model health laws conforms to the international health regulations and also allows for coordination between federal and state in terms of communication and in terms of partnership. And we have seen 5 states at the subnational level adopt these model laws, and we're hoping that once the assessment of the remaining 30 states are done, progress will be made in that respect to, for all those other states to adopt this model legislation at the subnational level.
Okay, I'd like to thank you for your answers. I'd also like to just push you a little bit on this important work that you're doing. If you encounter challenges, what do you expect them to be? Are these budgetary constraints? Are these relating to NCDC authority? Is there anything that we could think about here that might be important to reflect in our priority recommendations?
The major challenge actually is Budgetary, really, yeah. Because we do not have a dedicated funding line in NCDC for these activities. And then I'm trying to go back to areas that need, yeah. Basically, it's all budgetary. The training, everything revolves around budget, really, everything we have. Bureaucratic arrangement in the lawmaking process, that is not, I wouldn't say that has to do with budget. So basically, it's just budgetary, funding. That's the challenge, yeah.
Okay, thanks. I'm wondering, could we move back to the priority areas for actions? And I think that we can probably take both the legal and gender indicators together.
Yeah.
Okay, at this stage, I'd like to open this up to the audience in case you have comments or questions about the priority areas for action that are listed. Richard, I see one of our external evaluators has a comment, please.
The state-passed laws, do they specify financial contributions that states must make?
Can you take that? Yes, we have dedicated funding line in most of these state laws on public health security, just like we have in the federal laws, the NCDC Act Amendment, the Public Health Security Act. Likewise, the state laws, there are dedicated funding lines, yes.
Have those 5 states that have passed the law actually provided the funding that's stated in their laws?
Sorry, I didn't get that.
Did the states cough up the money?
They will. Since it's in the laws, they will. And actually, states have been very, very enthusiastic with this. Because of the recent outbreaks and the challenges we've faced, the states actually are looking forward to these laws coming up. So they are ready to provide the funding for public health security.
Can we have other comments?
I think we have another comment in the middle.
Yeah.
Gentleman in pink.
All right, thanks for a good presentation. Just a kind of an addendum. Reflecting what he says, I recall about 2 months ago in my state, in Ebonyi State, we would have our state annual plan, which the health security was budgeted for. So in line with what he's saying, the state is actually making budget to support health security. Thank you.
Okay, we have one more on that other side.
Okay. Good morning, and thank you for the presentation. I just wanted, if it's possible, to throw more light on the comprehensive gender assessment of legal instruments, and also to ask what the plan is for sensitizing the whole of the health sector, because there are a lot of trainings ongoing for gender-based violence and also gender equality, equity, and all that. So people need to know what the legal framework is for the country, to know how to channel their training tools and training instruments, and how to validate it, and to let it be that synergy. So we want to know what the plan is for that holistic view, and not just, because what I heard was training the legal people in the states. What about the public health officers that also need to know about these laws?
Thank you.
Okay, so just like I mentioned, this is a new indicator. We are working in-house to come up with a new tool for assessment of happenings around the public health sector on gender issues. So it's something we're still working on, so we can't really tell you this is how we want to, or how it's going to come out holistically. Yeah. You want to add to that?
Thank you very much. I would like to know whether...
Can you hold on? I
Sorry,
think that's
hold on.
additional comment.
Just to add further to what Barrister Sifia has said, gender consideration is different from what you have just mentioned. So from the legal perspective, we are looking at what does our laws speak to on gender issues. Are gender considerations included in our laws presently? And if they are not, how can we integrate this? Do our laws support gender equity, gender equality, especially during public health emergencies? So that's the scope of this indicator. And that's what we are working on to try to see how we could assess our laws and make plans to strengthen the laws in that respect.
Very important. So let's get a last feedback on this section.
Thank you very much, Legal Instruments team. I just wanted to know whether you are looking at legal instruments also in the veterinary sector, agricultural sector, or the environment, because we know all this affects IHR implementation. But when I look through your presentation, you're mentioning public health laws, and by definition, public health laws tend to more focus on human health, and we haven't seen a part of Veterinary Act, we haven't seen a part of biosafety and biosecurity, or laws that are in the health sector. So I want to be assured that you're looking at all the laws cutting across all the MDS. Thank you.
Yes, I would want to refer you back to our assessment of the federal laws first, the report we have on it. If you look at the report, it's comprehensive assessment of the One Health approach. All the laws relating to IHR, environment, animal, everything is included. Likewise, that is what we're doing at the states also.
All right, that's helpful. So we get back to the evaluators now.
Okay, we'll close this part of the discussion and just move on to the priority areas of action. Let's just go through them one by one. Conducting subnational legal assessments for the outstanding states. This seems very reasonable to me. I would ask whether you want to reflect here not only that assessment, not only the identification of the gaps and development, but whether you want to think about the revision or development of new legal instruments too. It's just as we move from one step to the next, do you want to capture really the essence of the next step in your priority recommendations?
Yes, yes, yes. We are thinking of that. It's in the pipeline, yes.
Sure. Is that better? Okay. Okay. Would you consider adding this to our priority areas of action for the report?
Yes, this is noted. It's noted. It will be added.
Okay, fine. On conducting the comprehensive gender assessment of legal instruments to identify gender-related considerations, I think this is very sound. Clearly, we are at a base level. This makes a lot of sense because it's a brand new indicator and one that we are still struggling a little bit to figure out how to assess, to use, to develop. So hopefully we'll have more tools in that area going forward. Moving on to the third bullet, the establishment of a framework for legal surveillance across MDAs, and this might ensure periodic reviews of all legal instruments in the country. My only question here is are there any prerequisites for this? Is there anything that you need to be in place before this happens?
We're working on developing a tool. This is kind of like a tracking mechanism to see occurrences in MDAs as regard to public health security laws. So we are working on developing a tool to help us with this tracking. Yeah.
Okay, so there's not another obstacle standing in the way to this
As usual.
This is just as we progress, you will have a tool.
Yes, yes. But then as usual, the usual thing, funding.
The usual. All right. Prioritizing legal capacity building. I find this very appropriate, and the prioritization, of course, of adequate funding for legal activities. I'm in agreement with these priority areas, with the exception we noted of adding a little bit of detail about the development of instruments at the subnational level. Can I ask if there are any other comments from my fellow external evaluators or co-lead? Okay, could we move to the score then for our legal indicator? Okay, so you have scored yourself at a 2, that you've conducted a legal mapping of relevant legal instruments at national and intermediate levels and documented where applicable. I mean, I will note that strictly speaking, we have not carried out an assessment at all intermediate levels, given the nature of the federal state, right? That said, I am happy for this to remain at a 2. Do I have any concerns about that? That's good. Okay. All right, thank you. With that, can we leave this at a 2 and move on to the slide showing the score for the gender equity and equality? Here we have a 1. As we've all said, this is a brand new indicator. We have not yet carried out a systematic assessment here, and so I find this appropriate. Are the external evaluators in agreement? Okay, I think then that we have agreement on the priority actions and the scores. I'll turn it over to you, our team lead.
Thank you very much for both the material team and the external team on this very important topic on legal systems and on the topic of gender equity. And it seems to be stated, but I want to congratulate you specifically. This is a score of gender equity because it is a 1 and this is showing a clear gap. And a clear gap, and we show it and we put the finger on it, that it's up to you always to do something. So by showing this to your decision makers, I hope we can, through our priority actions, do a lot to assist you in having more gender equity in the field. Thank you so much.
Thank you very much.
Thank you very much. My lord, you may exit the court. A comment after that? All right. Thank you very much again, the evaluators and everyone. Dr. Mike, you have a mic.
Sorry, good morning, colleagues. Sorry, I think my comments directed to WHO, especially on this JE 3.02. You know, now we have introduced gender indicator to the JE. But if you look at that, all the indicators and what is to be achieved, it's not under legislation at all. So if you are asking lawyers to talk about gender equity, all those that are listed there, we are not going to get it right. So we might consider actually taking it away from from legislation and put it maybe on the other IHR stuff, so that Ministry of Women Affairs can actually take the lead on this, and they can work with relevant Ministry of Health, Ministry of Agri, Ministry of Environment, SCDC, for them to be able to make sure that they put gender properly where it's supposed to be. But putting under legislation, it's confusing. If you read through the questions there and everything there, it's not for our lawyers to handle. Thank you.
We have other comments.
So I would just like to add, I mean, I second what the team lead has said, but I also want to say, I understand that it sits a little bit uncomfortably within legal instruments, but I do want to emphasize that there is a legal component to any comprehensive gender equality assessment. And so the way that this should be done is going through the laws, assessing what rights are given, how they are recognized, how they are enforced. And so I would say it is not a good idea to divorce this from where it sits in the legal instruments. I recognize it's a new tool. I recognize it sits a little bit uncomfortably, but I did want to add that. Thank you.
All right, so maybe we may be looking at ensuring that other relevant MDAs are part of the technical area so as to enrich the contributions from that. I think that will be helpful, pending when other reviews are done. It is the height of disrespect if a section is going on and you are having parallel discussions so much that we can all hear you. It is not good enough. So please, we're not saying no discussion, but let it not be to the pitch that we can all hear and we are interfering with the proceedings. Thank you very much. We move on to, I hope we don't have to make that announcement again. So for colleagues that are coming to present, please let's ensure that we speak more into the microphone. Our virtual participants are having a bit of struggle to hear us. So please let's get it a bit like this, if possible. All right. So moving on, we'll take the last presentation before tea break. And next it will be infection prevention and control technical area. So speaking for infection prevention and control technical area, the team lead for this section will be Dr. Muzami Gandaya from the Nigeria Center for Disease Control. A round of applause for him as he makes his way to the microphones. It will be heavily supported this morning by the following officers. From the USAID MTAPS, we have Dr. Chimeverem Nwoleri. Dr. Nwoleri, a round of applause for him. And we have also from the Federal Ministry of Water Resources, Mr. Olusoji Charles Ebofin. And from the National Arbovirus and Vector Research Center of the Federal Ministry of Health, we have Mr. Doguro Festus. A round of applause for the Nigerian team as they make their way to the podium. Thank you very much. And for they introduce themselves, definitely. You have the mic.
Yes, thank you. I am Dr. Guy Mulumodirwa, and IPC specialist working with WHO. I'm from Congo, TRC, and I'm the team lead for IPC. Thank you.
Thank you very much. Good morning once again, colleagues. I am Tendai Makamure. I'm an infection prevention specialist, and I'm with WHO based in the Nairobi Emergency Preparedness Hub. Thank you.
Yeah.
We can have you, Dr. Muzami. You have the floor, please.
Okay, thank you very much, moderator. Thank you very much, our August visitors in August, and to our distinguished panel of experts that are here present, my colleagues, senior colleagues, other dignitaries here present. I say a very good morning to you, still morning. So I will be leading the discussion for our technical area, which is infection prevention and control. And I have this singular task to actually present on behalf of my colleagues who are also here, some of which are not here. One of which is the National IPC lead, Dr. Tochi Joy Okwo, who is on leave. Next slide. So these are some of the abbreviations we'll be going through as we go through the course of this presentation. And for infection prevention and control, like all of you as experts here do know, that active IPC programs prevent healthcare-associated infections and protect patients, healthcare workers, and visitors. That is to say, IPC is universally a relevant component of all healthcare systems around the world that is critical and key to ensuring patient safety, healthcare worker safety, and then safety of patient relatives also. So it's a relatively new technical area. Previously in JE 1.0 and 2.0, we were under the AMR technical area, but we are happy to, pitch our own tent in this JE 3.0, and we are very glad to share with you the story of our national IPC program, the progress we have had over the years, and then certainly as experts, we are open to learning from you on how we can improve, on how we can certainly do some of the things we do better. So prior to 2017, there was no clear national IPC program, and IPC was more or less implemented in silos, and it largely disease-oriented. So by that you mean most of the vertical disease programs that we have on infection prevention and control are around TB and HIV. And those were not cross-cutting as far as the components of infection prevention and control. And certainly there was no coordination of healthcare-associated infection surveillance system. This was clearly missing prior to 2017. So our story began in 2019, actually, with the birth of the Orange Network. The Turn Nigeria Orange project is something that we at the NCDC and other colleagues that we have are very passionate about, and whenever we speak about it, we speak from the heart. Because on the 5th of May 2019, the then Senate Committee Chairman on Health, Senator Tejosho, together with the then DG, and then facility leadership of University of Abuja Teaching Hospital were the ones who actually gave birth to this program, which is the start of the National Infection Prevention and Control Program in Nigeria. Largely, what the Turn Nigeria Orange Network or program entails, it's that it is built around the WHO core components of infection prevention and control, the 8 core components as they are enumerated there, and it is our implementation strategy in Nigeria on seeing that Currently, where we are, or if you refer to the picture that is right top on the right, you see that the average patient in Nigeria continues to carry the burden of healthcare-associated infections and antimicrobial resistance. So we want to, using the WHO core components, be able to ensure that we take the healthcare system of Nigeria on a journey to where we are able to comfortably have visibility on data for HAI and AMR, and then certainly also use that data for action to inform policies and then inform how we improve going forward. And the building blocks for us to do that are the WHO core components. This is a framework that tries to depict how the Federal Ministry of Health, as the anchor parent ministry, supervises all of this. And then the National IPC program is domiciled at the Nigeria Center for Disease Control. So how that top or the upper part connects with the intermediate and the local government. And then at the intermediate level, we have the state IPC programs. And then also at the LGA level, we have focal points who actually take reports from IPC linked persons at primary healthcare centers. So very quickly to the main meat of the matter, actually. So for the first indicator on this technical area, we scored ourselves 3, and some of the reasons why we did that will be shown in the subsequent slide. But what we try to do here is to take a segmental approach in seeing that we dissect all of the provisions that are required in the benchmark tool so that we see how we satisfy that. So an active national IPC program certainly exists, like I mentioned, starting from 2019. And by active here, what it means is you have dedicated people that are trained, and at the acute healthcare facility level, at the minimum, we have 1 dedicated person that is also, trained. The WHO recommendation is 1 per 250 beds. And for policy level, institutions and, at policy level, like the National IPC program, we have those dedicated human resource. And a National IPC operational plan, according to WHO minimum requirement, is available. A role of IPC in outbreaks and pandemics is clearly stated. So we have a National Infection Prevention and Control strategic plan that details all of that. It's important also here to state that the operational plan or the strategic plan we have is actually built around the core components. So all of the 8 are adequately represented with activities, indicators, and targets set for all of those. And then also the benchmark requires that national guidelines, standards for IPC in healthcare are available and disseminated. This, we have the National Infection Prevention and Control Manual, and for us, it's a compendium of the standards and practices that are expected at the healthcare facility level. Also, we have other vertical or disease-specific guidelines here, like viral hemorrhagic fever, monkeypox, and diphtheria as well. Selected healthcare facilities are implementing guidelines using multimodal strategies, including healthcare workers training and monitoring and feedback. So very important here is to introduce the concept of the Orange Network. So the Orange Network is a group of healthcare facilities supported by the Nigeria Center for Disease Control, of course, and our partners and other stakeholders in seeing that we structure the IPC programs across those facilities based on the 8 core components, and that we are able to, over some time, support them in becoming centers of excellence for infection prevention and control. And at the minimum, the WHO minimum requirements are adequately satisfied at that level. So this is just what I try to explain, some of which is here, an active national program, National IPC strategic plan, and then the manual also, and other disease-specific guidelines, and then the network is clearly enumerated here. So at the tertiary healthcare facility level, we have 41 healthcare facilities that are actually working in that space, and at the secondary healthcare facilities, we have 81 across 11 states. So our unique approach, like you will come to see in subsequent slides, is that we don't go all out to just say we are rolling out something for rolling out sake. we try to pilot it in a small scale and see what we can refine and understand so that we are able to inform how the scale-up will happen going forward. And that there is also a documented criteria on how facilities can actually belong to the Orange Network, part of which is you must appoint a dedicated infection prevention and control focal person at that level. So use of multimodal strategies in implementing these core components, certainly this is the way to go, because we're doing a human-centered design, and then a lot of IPC is about behavior change. So if you want to change behavior, certainly the bimodal and the unimodal approach is not the way to go. So you have to use the multimodal approach. You build something, you teach it, you ensure that it works by checking it, and then you sell it to people as reminders, and then you build this culture of institutional safety. Also, we take very much pride in sharing our story that we have with the College of Medicine, University of Lagos, in training infection prevention and control professionals. So that goes through basic, intermediate, and advanced certifications, and it spans across a period of 8 months. Orange Network, DIPC training reports, SSV reports, and some of the response guidelines that we have for disease-specific programs will also buttress the point that we have made that it's not just HCI-centered, but also we have for other outbreaks.
Sorry,
so,
Dr. Muzami, you have 2 minutes more.
2 minutes, okay. So an active program exists nationally, and then importantly what I want to mention here is that it is linked to the AMR program. It is linked, as it was shown in the previous presentation, I think from 2 days back or so, that within the governance structure of AMR TWG, IPC is a fundamental pillar there. Most of these things that are actually on this slide, I have enumerated them, so I'll just go forward so that we don't have to continue dwelling on them. Also, very critical to mention is the tools that we have for some of these assessments, and then our PALS approach, which is a participatory approach to learning and system, is the behavior model, human-centered approach that we deploy in facilities to change behavior. So for the second indicator, we scored ourselves 2, and it says that National Strategic Plan for HCI Surveillance that include a list of priority pathogens, is also available. So why we did that is because we have a strategic plan for HCI surveillance, and then the strategic plan also on broader IPC, and then a protocol for conducting SSI surveillance is available, and then a pilot report that we actually did at the level of the Orange Network. So importantly also to mention for the next indicator, this we happen to score ourselves to, national standards and resources for self-built environment, wash, screening, isolation areas, and sterilization services in healthcare facilities, including appropriate infrastructure, materials, and equipment for IPC, as well as standards for reduction of overcrowding and optimization of staffing levels in healthcare facilities, according to the WHO minimum requirement. Exist, but they are not fully implemented through a national plan. So this is what we were able to document as rationale of why we actually scored that. WASH guidelines are available, the manual is available, the policy is available, and then the strategic plan also is available. For strengths and best practices, all of that are documented as well. Very importantly, I think, is to just go to the areas that need strengthening. Visibility, advocacy, so that we are able to deepen the approach. Legal framework development is something we are working with stakeholders to see how that can go forward. And then developing curriculum for pre-service training of healthcare workers, improvement of budget for IPC, and then ensuring that we expand the pool of IPC professionals so that we take it beyond the mark of the current 245 that we have in country. Areas that need strengthening still, improvement in WASH, and then strengthened ability to do HI surveillance. This is key because on the indicator with the benchmark, if you check, we are required to actually include secondary healthcare facilities before moving to the next stage. So for the pilot, we were just able to do that across tertiary healthcare facilities, and that is part of why it remains that. So for priority actions is to secure approval and signing of the revised national IPC policy by the NCH, and then finalize the legal framework, and then see how we can scale up and deepen IPC programs implementation across subnational levels, and then develop and implement budget advocacy plan for IPC, and then develop national IPC training plan, pre-service and in-service, incorporate secondary healthcare facilities in the HI surveillance matrix, like we have mentioned, conduct WASH fit assessment, and then improve built environment, including WASH and drive program implementation. So these are some of the references and supporting documents which are all documented in the link that we shared. And this is also it. So this is a list of some of the people that supported this technical area and of course leading up to this presentation. So thank you very much sincerely for your time.
Thank you very much, Dr. Omuzami, for doing justice to this. The evaluators, the floor is yours, please.
We'll start to congratulate Nigeria team. You really have done a lot about this area, infection prevention and control. And maybe I will start with just small reminders about WHO recommendations. So first, every country must have an active IPC program with a work plan, annual work plan, budgeted annual work plan, with a secured budget, and also with a focal point. That we can call an active IPC program. So, under this IPC program, we have institutionalization of IPC with all those regulatory texts, term of references, all those things. Under IPC program, we have also advocacy for budget and also IPC coordination. Under IPC program, we have also, we need also to include IPC in Nigerian multi-hazard plan. That is highly recommended. And also all those things must be really supported by a safe environment in health facilities. And there you need really to have all those standards for safe environment, national standards. So here people do confusion between standards and the guidelines. We have to be careful. That's why really we will need to see, we said that we are having standards. We'll need really to see the standards, if they are really standards or they are guidelines, before we agree with you in that. Okay, that is about the first recommendation, IPC program. The second thing is there are updated guidelines, national, and also in subnational also guidelines and SOPs. The third thing is education and training, and the last one is this healthcare associated infection surveillance. So every country must have a plan of FKR, a strategic plan of FKR associated surveillance. And also, every country should start now with, I think that Nigeria have started already with the prevalence survey, I think. The prevalence survey.
PPS?
The prevalence survey. Yeah, okay. And also, you should consider both tertiary and secondary health facility, healthcare. So I think those are the high recommendations. And if you consider all those recommendations, we should come back to your priority actions. And I think we should reformulate them. So before I give you the floor, I ask to my colleague Tendai to give her comment.
Thank you so much, and I want to extend my congratulations also to the Nigerian team. Maybe we can give them a round of applause because Nigeria is one of the, for IPC, it's one of the countries that are doing very well in infection prevention control, and I think you have seen the best practices, and they will need the support from all of us for the program to continue excelling. So I'll go to the slide on priority actions, if you can project that, please. On this one, we can see that most of the priorities that they have listed, they are focusing on institutionalizing the IPC program, and would recommend that the issue to do with budget, as you have clearly articulated, an active program needs to have a dedicated budget. And if that component is still missing, it's difficult, despite all the milestones achieved, to consider it an active program because that component is still missing with a dedicated budget. So I see you have developed and implement budget advocacy plan. This, I think, in the policy and also the legal framework, they can all be compressed to fall under one. I also wanted to ask on the priority on developing a national IPC training plan. Okay. Do you currently have an in-service training curriculum, not training package or training slides, but a curriculum that articulates well what is supposed to be trained for the basic, intermediate and advanced levels as in service? And also I've seen you shared on postgraduate, which is very good, but our key interest, if we could have a curriculum for that covers pre-service and in-service. Also, you said you have guidelines. We also want to find out when were they developed, because guidelines, the national guidelines for two, and how far widely is the dissemination of these guidelines, because it's also a key indicator on the availability of these guidelines in all the healthcare facilities. I remember from the initial presentation, we had 34,000 health facilities. How is the coverage there of the guidelines, the implementation, and the monitoring of the implementation of the guidelines? Then on conducting WASH-fit assessments, I'll give to Dr. Gee to comment on that. But the WHO tools, the infection prevention control assessment framework for facilities, we have a tool for minimum requirements, which takes into consideration the WASH-fit component. So it will be focusing more on having an M&E framework for the healthcare facilities, which uses that tool, which combines all the IPC components and the WASH-fit elements. Okay. And for the built environment, lastly, from the rationale that you have given, there is no standards for safe built environment in the healthcare facilities. There is supposed to be a national standards developed in collaboration with other sectors of infrastructure development and IPC and all the other units, environment, which clearly articulates the standards on design of healthcare facilities, the facility layout, incorporating all those key indicators that have been highlighted in the indicator. Thank you.
May I respond? Okay, thank you very much for the very interesting comments you passed. And for some of them, I would say this. So for the issue of budget, often, and I know you know this certainly, that what people often forget is human resource salaries of staff that work in an institution that has the mandate to carry out their work is also part of budget. I can tell you the federal government of Nigeria pays the salaries of dedicated IPC personnel at the Nigeria Center for Disease Control that are just focused on doing IPC work. So I think this is a milestone from where we used to be to where we are now. And then to specifics on the budget also, if you check the 2022 Appropriation Act, and then the 2023 Appropriation Act also, you see we have budget lines for IPC activities. If I recall clearly, in 2022 it was 40 million naira, and then in 2023 it increased by 10 million to 50 million naira. So we have those things. Probably time didn't, permit for all of this information to be said and documented on the slide. But as far as the requirements for the program are concerned, I think we are good. Yeah. So other questions were asked regarding standards and guidelines. We really are very open to seeing how we can, improve in that regard. And of course, we are heavily reliant on the WHO and other experts in seeing how we drive this piece of work. But one thing I would like to also state here is, if you just refer back to a few slides before this, I think the one on program. Can you go back? The first indicator, 4.1. Yes, very clearly. So it states here that national guidelines / standards. So the understanding we had is that as far as the benchmark tool is concerned, and then if you also peruse the tools, or the manual and the guidelines we mentioned, you will see that they do actually make an introduction on how the setting should be of maybe a service area, and then go on to state, the stepwise approach on how that service can be rendered in a way that doesn't harm the patient and then doesn't harm also the healthcare worker. So they were used interchangeably here, or with a stroke or a slash. So that's why we felt, we could as well use that. And if you look at the document critically, you will see some of what I am saying. But certainly, I agree with you, we can certainly improve in that regard. I don't know whether my colleagues here have any comment for any of the questions that was asked.
Thank you very much, Dr. Muzamil. I think in addition, there was a comment on the curriculum, and the current standard for the country, the College of Medicine at the University of Lagos, working in tandem with the IPC unit of the Nigerian Center for Disease Control, as well as other partners, developed the curriculum for the various levels, the basic, the intermediate, as well as advanced levels for in-service training for health workers across the country, because there was an identified need to really upskill and provide the necessary capacity strengthening for health workers in infection prevention and control that is outside the routine trainings that have been ongoing around the country. A lot of trainings have been done both at the national, sub-national, even at the primary health level as well, at facility level. But we needed to have something that we can be sure of that standard for training, and that's what is ongoing currently with the IPC diploma program. So there is a curriculum that dictates what needs to be covered for each of the levels at the basic, intermediate, as well as the advanced levels. Thank you very much.
Thank you. Okay, thank you. Maybe I will give the floor to the external evaluators before I give the floor to the public.
Okay, thank you very much. Maybe just on your priority slides, where you have your IPC priorities. So I see that you have successfully integrated healthcare associated infections into the primary level, and you are planning now on incorporating at the secondary level health facilities. National Health Associated Infection Surveillance.
Incorporate secondary healthcare facilities?
Yes.
Are you saying
so my understanding is you have already incorporated at the primary level. You have it in place already?
No, I'm afraid that is not a recommendation by the WHO. HAI or HCI surveillance if you peruse the manual for IPC, you see that it starts at the minimum in the secondary healthcare facilities. And it's for obvious reasons of lab and personnel and expertise and whatever, which may not be available at the primary healthcare level.
Okay, so, do you have something in place already, or you just beginning and maybe that was mine?
So the normal, the service pathway that is currently available is if a patient is seen at the PHC level, and then for some reason, while receiving care at the facility, they develop healthcare-associated infections. They may not have the capacity, the equipment, and even personnel to identify, diagnose it, so they may have to rely or refer into the next level of care. And then the next level is the secondary health care facility. So at the minimum there, you expect that some microbiology services should be available, and then some clinicians also should be able to see this and see how they can approach that. If it's not there, then they send to a tertiary healthcare facility level and see how that can be treated.
Okay, thank you. So my point was on if we already have something in place, how have we used the data maybe to inform the policy on AMR and stuff like that? I'm trying to just link maybe for learning purpose from you. If you've already started something, how have you used the data from the HAI surveillance data to inform policies on AMR?
Okay, so like I mentioned, very much linked to the National IPC program is the AMR program. And I mentioned at the minimum 2 points of intersection where the two programs actually interlink. In the governance structure, IPC is one of the principal pillars that are expected in the TWG, where we share findings, share reports, and then co-learn from one another. If you check the AMR surveillance guideline, you see that there are lists of pathogens of interest that are actually highlighted. In our HCAI surveillance strategy, those pathogens of interest or priority were directly taken or linked from there. So in other words, through our HAI network or network of healthcare facilities, once we are able to identify any of these pathogens of interest, we require the isolates to be transported to the National Reference Laboratory in Abuja or Ibadan, as the case may be. I hope that answers your question. So we have this network of people that do the HAI work, and they do that.
All right, thank you very much, Dr. Muzami. I think that is clear. Are there other questions?
Yes, we can give you one question to the audience, because we don't have time.
Okay, so let's start with you.
All right, thank you so much, Dr. Mohammed, for that presentation. Just to add, some of the things we are doing with respect to infection prevention and control that are not captured in the presentation. In Nigeria, we have CHIPS program under the Federal Ministry of Health, piloted by the National Primary Healthcare Development Agency, which is also part of infection prevention and control activities we are doing at health facility level. And we've gone beyond the health facility level, the primary healthcare setting, up to community level, ensuring we have people within the community that are helping with community health influencers, promoters, health promoters, services, and programs. So what they do is to link people within the community to health facilities, and they also help in ensuring that they sensitize and educate people within the community on IPC measures. Then we also have NEMCHIC program that takes care of essential health services that are being provided at primary healthcare facilities, to some extent even at secondary healthcare facilities. So they tend to focus on maternal, newborn, and child health, as well as health promotions within the health facilities. And there has been also a strong collaboration between the World Development Committee and the health facility. So within the health facility, especially the primary healthcare setting, the Ward Development Committee chairman is the chairman of that committee. Then the health facility in charge, who is the OIC, is the secretary of that Ward Development Committee. So what they do is to ensure that infection prevention and control is strengthened at the health facilities level. And within the health facilities, with support of partners, there has been incinerators built so that waste generated within the health facilities are properly controlled to prevent infections spread. So where we don't have such incinerators built within the health facilities, some states have them, some organizations have them. So there is an understanding between the health facility, local government, and state government to make sure that those wastes are transported to either the local government health department or the state health department, and they are evacuated to where we have those incinerators to have those wastes properly disposed. And another area I think we also need to look into with respect to IPC is to see how we can strengthen advocacy to the Governors Forum to see how they can commit resources, especially at subnational level, to see how IPC can be strengthened, leveraging on basic healthcare provision fund and the impact fund to strengthen IPC activities at that level. And there should be accountability in place so that the quantity of those IPC commodities that are deployed to health facilities should be properly accounted for. We have seen instances where some people use some of those PPE materials to clean their legs and they throw them anyhow. So if we have accountability, they are going to be properly used and wastage is going to be minimized. Thank you.
Yes. I think very quickly is to state that this is really critical, especially his last point to the first indicator, which is 4.1. The only reason why we can't be at 4 is that 75% benchmark. So it requires that you would have deepened and expanded the program beyond, a few facilities to 75% of healthcare facilities, both public and private in Nigeria at all levels. And that is an enormous work.
Absolutely, I quite agree with you.
Thank you.
Okay.
We have more bets. Are we able to take any one more, or we're okay?
Okay, one more.
Okay, so let's take one more.
Okay, so thank you, Muzamil, for that. So I actually had two observations, one on community IPC, but I think that has been responded to. So the other one is, I'm just curious if the team is desiring to see a career pathway for IPC professionals. If so, how do you advance that discussions as part of your advocacy package? Because I agree, quite frankly, we need not only the in-service, the pre-service, and I've seen enormous work have started around that area. So it's just something I'm bringing up for you to consider. If that has not been part of the plan, it's actually a good idea to see if that is looked into. And I'm sure you forgot to also mention, because I am also passionate about IPC, I connect with you in that. So, and I feel, yeah, you've been doing a lot, even the onboarding across disciplines. You also do a lot of onboarding trainings, for healthcare workers, even the outbreak component and all of that. So you are really doing enormous. I'm just like speaking to some of those things that actually you've not mentioned. So those are my few comments. Thank you for the work you are doing.
Thank you very much for your excellent comments. I frankly agree with you, and it is part of what we have as recommendations or next steps to ensure that we have this dedicated or defined career pathway, especially for IPC professionals, where you can have a health degree background and then do an IPC course or certification that takes you to the advanced level, and you can be hired based on just being in the facility to render IPC services. And that is done in many other countries. We are certainly seeing how that can be expanded. Also, to state that some facilities, largely tertiary healthcare facilities, do have these dedicated, hired people just for IPC. But even them, they don't have a defined career pathway. So we have IPC nurses that are hired just for IPC work, but for them to get their regular promotions within the civil service, they will have to go through the nursing pathway. And I think it's the same also for epidemiologists and then some other professionals that are in this room also. So it's a gradual approach. That's how we have always viewed it. What we want to first try and do is to ensure that they are available, like they do the work. And then as far as their hiring is concerned, we want to make sure that they are hired, and how their promotion happens, maybe it should be a target that we can target right after that. But for now, we want to ensure that they are widely available so that they are able to design programs that prevent healthcare-associated infections and reduce the burden of AMR. Thank you.
Okay, right. Thank you for all this discussion. I think we need to progress in the sake of the time. And for the priority actions, please, I think we will need to reformulate because if your operational plan is really done according to WHO minimum requirement, it should take into account most of these priority actions, like institutionalization of IPC program, with that legal framework. It will take into account also, all those are really the priorities. It should take into account also the monitoring, evaluation, and feedback. Okay? So I think we will need just to see it together. And we can recommend that just to update and implement the operational plan. We'll arrange together in the site meeting. So let's go back now to the scoring, if you permit. For the IPC program. Yes. Then I think, I will give, as we give a 2. Why? Yes. Why are we giving a 2? Because I think that we'll need to see, it's a provision. Yeah, maybe we'll go back to the 3 after seeing all the documents. Because we said we are having them, yeah, we'll need to see the operational plan. If it really is with line, if it's in line with WHO minimum requirements, okay? Now I will ask the team also if it's okay with you. Okay. So, are you satisfied with that?
No, we respectfully disagree.
Sorry?
I said we respectfully disagree, sir.
Okay, I think what the team lead is saying is that it is a provisional tool. He wants to see more. This means that I will kindly ask the Nigerian team and the external team for this indicator to go to a site meeting. Maybe for other indicators as well, but already you are in a site meeting.
Okay. Yeah. For the second one, which is healthcare associated infection surveillance. Yeah. I think also maybe here we'll agree also, but with you, it's we are at the level 2. We agree with you. But also we'll need to see it if really it includes all those pathogens that are antimicrobial resistant. It should include all that. So we'll see it together.
All right, thank you.
Okay, the team, do you have a comment about that? You agree with that?
They all agree.
Okay, Fine. For the last one, which is the self-environment, there too also maybe I'll bring you back to one. It's also a professional. Yes, we need to see the. It's a professional also. Okay. Also, there we need really to see if Nigeria has national standards. Yes. Thank you. Over to you.
No, you are proposing a one. Now you have to ask the external team. Do you agree with the proposal of the team lead? They are in agreement, so now we have to formally propose to the Nigerian team for the third indicator a one, but I think you are in a disagreement with this.
So thank you very much. I mean, you're generous to even give us a one, right? But really, we strongly feel we are two, and for some of the reasons I mentioned. First, within the benchmark tool, you find the word guideline and standards being used interchangeably. Do we agree on that? So I showed you in the first 4.1, in the benchmark, they said guidelines/standards. Right, there, guidelines.
May I, because we are now not discussing anymore. Okay. We are proposing, okay, and we are agreeing that we are disagreeing.
We are two, sir.
So you stick to a two, and this means that there are two indicators that you need to discuss in a side meeting. So for now, for the plenary, I would like to conclude by thanking you. But before going to tea, I would like to ask the moderator if it is permitted to ask a personal question to the IPC team. And then I would like you to turn to slide number 5.
Okay. Thank you.
If we can turn to slide number 5.
Slide number 5.
5.
No, slide 5. Slide 5. The 5th slide. It is showing of.
It's not me.
Yes. Yes, you are turning Nigeria orange.
Yes.
I have to confess that I'm from a very small country in Europe.
Okay.
This is the Netherlands.
Oh.
We are 10 times smaller than you are. We have only 70 million people. You have 200 million people. If I look at the map, where your roadmap starts is where the Netherlands is. So you are taking the orange color from our country, because orange is our king is orange, our soccer team is orange. So I would like to propose you, let's walk together. Don't take the color from us, but let's walk together on IPC.
Thank you very much.
Okay. Thank you very much, Dr. Hank, and to the team. So from what we've heard, we have not heard the last from the IPC team. They will be going to a side meeting to finalize the other issues. But you will agree with us that they've done a great job over the last couple of years. This is a new technical area, and a lot has been achieved. A warm round of applause again as they go back to their seats and to the side meeting. Thank you very much, distinguished. Okay, it just occurred to me that today marks the 9th year that Nigeria discharged the first Ebola case. So today in history makes the 9th year our first Ebola case was discharged. And that speaks eloquently to how far we have come as a country. Those of us who are part of the response in 2014 can relate. Thank you very much for all the great works over the years, and we can see the role IPC have been playing since then and the progress we have made. So far, I think it will be another time to appreciate the team lead as he makes his way back to his seat as we take a break. So we will be having a tea break now for the next 30 minutes. And we'll be back in the hall by 12:15. Then we'll be starting with the resolution of the last two technical areas. I think we have two now. Three technical areas. No, I mean the ones that have not given us their final positions, those that need to have side meeting, we need to take the feedback. But then we go into the last three presentations. So let's get ready, and we'll be back after the next 30 minutes. Tea is served. Thank you very much. A very good morning, everyone. get seated. We're officially done with the tea break. Please, let's get seated. We need to move on with the proceedings. Thank you, everyone. It's difficult to tell people who are in charge of money to sit down. But Dr. Mike, if you don't mind. All right. So I'd like to wish us a very warm welcome back from the short tea break. So we move on with the last set of presentations for this evaluation. So we will be going straight to the immunization technical area. Again, can I announce that we are back in section? Can we please leave the other conversation for now and the pleasantries so we can get back to business? Thank you, everyone. So let's welcome the Nigeria team on this side of the conversation on the immunization technical area. It's my pleasure to welcome Dr. Dogo Bala from the National Primary Healthcare Development Agency. Dr. Bala, a round of applause for him as he makes his way to the podium, please. He will be also joined by Dr. Obi Ezebulo from the UNICEF. Thank you for those who are clapping. And from the Nigeria Center for Disease Control side, joining the team, we have Dr. Bola Lawal. Thank you very much. I'm aware there's someone from Afinet who is meant to join the team, maybe when he comes. But before we go on, we'd like to bring forward the consensus that has been reached now by the Health Service Provision Technical Area. And it's our pleasure to welcome the leads for this engagement to brief the House. You have the floor, sir.
Thank you, MC. The DG NCDC, distinguished participants, the Health Services Provision Technical Area has been able to reach a consensus with the external assessors and facilitators. So we've jointly agreed on our scoring and agreed on a score of 1 to 2 for the 3 indicators. And I think with this, we are home and dry. Thank you.
Thank you very much. I would like to thank you, the Nigerian team, for a very good and friendly and understanding discussion, very engaging discussion, and we reached the consensus scoring of 1, which was agreed on the stage, and only the indicator 2 that was not previously agreed on, and then we had a discussion at the side meeting, and we came to the consensus. We remain at the score that was initially provided by the country team, which is 2, and it was a consensus decision. Thank you very much.
Thank you very much. Thank you so much. So it's not every time there's a side meeting that the scores go down. So it can still remain at it depends on the superior provisions of the document and other understanding provided. All right, so let's welcome the external evaluators for this section on immunization. I saw Professor Richard earlier. Okay. So we'll be glad to have them join us now. So we know them already. It's just to know who is the lead for these engagements and the co-lead, and then we take the conversation on from there. Tony Blair, sir, you said that's what you want to answer today. Professor Richard, you wanted a new name today. Maybe you want them to know the new name.
I hope you know by now that I am Richard.
Yes, I think already you know me, but just to mention again, Buba from Gambia.
So we are here to discuss the technical area on immunization, and I would kindly give the floor to the Nigerian team for their presentation.
Good afternoon, distinguished ladies and gentlemen. I'll be presenting the immunization pillar on behalf of the team we have here. I beg to stand on existing protocols. So what we have before us here is just some of the abbreviations we'll be encountering in the course of our presentation. Now, to give you just a little bit of background about the National Primary Healthcare Development Agency, which is saddled with the responsibility of overseeing immunization activities in the country. The National Primary Healthcare Development Agency is the implementing body for immunization services in the country. And the department that has been saddled with the responsibility of planning, supervision of routine immunization, supplemental immunization, outbreak activities, development of guidelines, and outbreak response activities is the Department for Disease Control and Immunization. And there are some responsibilities that the NPHCD oversees. For instance, the management of the delivery of routine immunization services, the introduction of new vaccines, campaign implementations, reactive vaccination to outbreaks of vaccine-preventive diseases, vaccine supply chain management, and data management. Sorry, I think there's a technical problem with this. Yeah. So, one of the mandates of the National Primary Healthcare Development Agency is the development of partnerships. And no wonder we have an area of these stakeholders who are there to support the agency. For instance, the donor partners, we have Gavi, BMGF, FCDO, JICA, we have them giving us financial and technical support. International organizations such as WHO, AFENET, who support us financially and also give technical support. We also have government ministries, departments, and agencies like the Federal Ministry of Health, the State Primary Healthcare Development Agencies that provide policy guidelines, planning and implementation, and of course, we also have local implementing partners like Sidani, Solina, and Chan. They also offer technical support. Now, the first indicator we'll be looking at under immunization is the vaccine coverage for measles as part of our national program. The federal government allocation of funds for immunization. We're looking at our strengths now. The federal government allocates funds for immunization and PHC programs. That is one of the strengths of this indicator. We also have strong technical expertise and capabilities. Service delivery, that is in terms of the provision of routine immunization services, is across all local governments in Nigeria, numbering about 774. We also have service extension across the continuum of life. Then the best practices we engage in include the integrated service delivery, so that clients receive a continuum of preventive and curative services according to needs over time. It incorporates everything, both the routine immunization and other primary healthcare services. And of late, we are talking about the solarization of PHC systems in about 100 local government areas in 18 states that have been prioritized. This is one of the PHC transformation agenda we have in the agency. And of course, budget for vaccine procurement and management is dedicated as a first-line charge in the health budget of Nigeria. In terms of weaknesses, funding has been an issue. Rural allowances delay and sometimes non-payment of salaries, inadequate funding to conduct sessions as planned by the RI providers. Then what about the human resource for health? Of course, it's inadequate. And sometimes we also experience attrition of workers, and then there's poor motivations as a result of this. The health infrastructure and equipment are dilapidated. We have immunization data management, optimization of the DHIS tool of paramount importance, and also our vaccine supply chain and logistic management too are not devoid of issues. Then for challenges, we have resource constraints that affect various aspects of our immunization program. We also have data management issues that can hinder monitoring and improvement of immunization coverage. And then equity issues can also lead to disparity in the coverage of our immunization. So for the first indicator, our score, as you can see displayed, is 2, which simply means about 50 to 60% of the country's 12-month-old population have received at least 1 dose of measles-containing vaccine, as demonstrated by the coverage surveys or administrative data. Then there's also a plan in place to achieve 90% coverage within the next 5 years and include supplemental immunization activities. Now, let's quickly go to the second indicator, which is the national vaccines access and delivery. The government of Nigeria has been fulfilling its co-financial obligation on the procurement of routine immunization vaccines as well as counterpart funds for supplemental immunization activities. We also have committed leadership with institutionalization of national logistic, zonal, and state logistic working groups. These are our strengths. And then availability of immunization supply chain partner support from the partners I listed earlier on. Availability of structures at the national and sub-national level. We have skilled personnel. And then, of course, there's improvement in the delivery of vaccines to the last mile. Now, looking at our weaknesses, that is areas where we need some strengthening. Of course, I've talked about the human resource gap, which needs to be improved and cannot be overemphasized. We have capacity building to compete with the global standard for supply chain management. This is really needed. Then real-time visibility in terms of vaccine stock management at health facility level. This might be at the national level, but we want them at the lower levels too. And then storage capacity at the national level would need to be expanded. Implementation of the EVM IP, especially at sub-national level, which states that only 40% of states showed progress from 2017 to 2020. And then the annual work plan implementation has to be addressed too. Some of the challenges we face, infrastructure challenges can disrupt the cold chain and hinder vaccine delivery. The bottom line is that we need more of the spaces. And then resource constraints can affect various aspects of the immunization program. Now, based on the evaluation that was done, we scored 4. And under 4, it simply talks about the vaccine delivery, that's cold chain maintenance, is available in about 60 to 79% of districts within the country, or vaccine delivery, that is the maintenance of the cold chain, is available in 60 to 79% of the target population in the country. Then functional vaccine procurement and forecasting takes into account global stocks, lead to no stockouts at the central level and rare stockouts at the district level that are within their control. So the emphasis here is on the percentage coverage. That is the target population that can be reached is about 60 to 79%, while the cold chain is also within that range. So for our strengths in terms of this indicator, we have a very good coordination structure for implementation. We have a partnership with international organizations who provide significant financial and technical support. We have regular training and capacity building for health workers and logistics personnel. And we have a robust community engagement to help reach the marginalized and vulnerable populations. And of course, we integrate services in our campaigns. Our best practices also includes integrated service delivery during mass vaccinations and also during routine immunization activities. Then the use of validated human resource for our campaigns. The development and adherence to the decision matrix and the determination of readiness by the states that will be implementing. And of course, the signing of memorandum of understanding by states prior to the various campaigns we hold. Then the release of counterpart funds as a requirement before the implementation of campaigns by states. The institutionalization of traditional and religious leaders committee on PHC delivery at subnational levels. Of course, you know the roles traditional and religious leaders play in trying to up coverage for us in various routine immunization and supplemental immunization activities. Of course, we are not devoid of weaknesses. One, which is the increase in political commitment and ownership of outcome of campaign. That is a bit lacking. Then timely release of counterpart funding by the states. Financial and process accountability at subnational level. And of course, the ever-appearing human resource for health, which is a problem for us. What about our challenges? We depend highly on donor funds. I think it's time we take ownership of this and commit ourselves financially. There's vaccine hesitancy in some communities, which can reduce the uptake of vaccines. And then equity issues and insecurity lead to disparities in our immunization coverage. For the mass vaccination for epidemics of vaccine-preventable diseases, at the end of the day, we scored 4, which reflects that there's a national plan for mass vaccination response to outbreaks of vaccine-preventable diseases, including national guidelines for regulatory approval and acquisition of new and experimental vaccines, and relevant standard operating procedures are disseminated and implemented at all levels, cutting across the national to the local levels. So, of course, we will need to discuss the rationale behind the grading of these indicators. So for the first one we discussed, which was vaccine coverage, looking at measles as part of our national program. In 2017, we scored 3, and in 2023, we scored 2. This cannot be unconnected with the advent of COVID-19 pandemic, which interrupted our routine immunization services, resulting in a decline in the measles containing vaccine 1 coverage from 73% in 2017 to 60% in 2022. And of course, there's a strategy in place. That's the Nigerian Strategy of Immunization and Primary Healthcare System Strengthening, which has outlined strategies to achieve 84% coverage within the next 5 years in routine immunization, and then looking at about 90% coverage in supplemental immunization activities. For the second indicator, which is national vaccine access and delivery, in 2017, we scored 4, and in this year, it still remains the same at 4. And the rationale is that there's an advanced plan in the construction of 3 hubs in Kano, that is vaccine storage hubs in Kano, Lagos, and Abuja. Then, of course, the implementation of the cold chain equipment optimization platform, leading to about 97% of watts with solar direct drive refrigerators for vaccine storage. There's also the annual vaccine forecasting that we do with buffer stock to avoid stockouts of our vaccines. Now, for the last indicator, which is the mass vaccination for epidemics of vaccine-preventable diseases, it's making its entry this year. And the rationale is that there's an existing national measles elimination strategic plan to cover 2019 to 2028. And there exists an immunization policy guideline. And there's also an existing measles outbreak response guideline, operational guidelines also for our vaccination teams. There's also a plan to introduce the measles rubella vaccine into the immunization come 2025. So what are our priorities for action? First, we want to strengthen PHC leadership and governance at the subnational level. We want to implement our accountability framework for immunization, and also strengthen primary healthcare funding at the subnational level. We're also looking into the idea of local vaccine production, cold chain storage capacity and logistics infrastructure expansion, and then immunization program ownership at sub-national and community levels. We also want to look at our data management for immunization in order to improve it, and we're also hoping to collaborate with the Ministry of Agriculture on zoonotic diseases to reduce risks to humans. And we also want to sustain ongoing efforts to strengthen collaboration with civil society organizations. Thank you very much.
Thank you very much, immunization. Evaluator, sir.
Measles immunization is like an X-ray on the healthcare system. It's our opportunity to take a pulse every year on how the system is performing. And in the case of Nigeria, you can see the important difference between the capacity of the system to do things and its productivity, what it is actually able to produce. Nigeria is underperforming in terms of measles immunization to young children. With your planning and organization, with your healthcare facilities, with your cold chain in place, with your national funding and with your partners' funding, you have the ability to have higher than 70, maybe higher than 80% coverage among young children. And at this time, your coverage is estimated to be around 54%. So this is why JEE moved from just measuring what is in place in terms of the ability to how we're using it. And this is where it gets really interesting. Measles coverage for young children in Nigeria has gone up and down. And that's real life, you know, because you could say if you build a cold chain, we have 30 centers, and then we have 40, then we have 50. It looks like things are naturally always going up. Capacity generally is building, but functionality depends on what you're doing, and that goes up and down in real life. We didn't start out with JEs with the possibility of measuring decline, but Nigeria correctly moved from a 3 to a 2 on measles immunization because immunization is not as high as we had thought it was and as high as it could be. It goes up and down 10 or 15% a year, quite a big difference. So what you do makes a very big difference on the results that you get. I think most of your scores are very good. I think you certainly have developed the capacity, as I've just said in a way. You have the building blocks in place to have the good immunization levels. And then you see the irony of a score that I think you correctly put at 2 because you're under 69% coverage. So it has to be a 2. So our questions have to do with the actions that you're planning to take and need to take in order to have your score of 2 get to a 4, like your score on your abilities. It's quite notable that immunization coverage for measles in the 3 Northwest states where there has been conflict is half. Every year it's half as high as the South. These are areas, as you identified, that have some cultural resistance and access problems. So certainly, if you're running the system, you have to pay a lot of attention to improving access, working with local communities. And this is where health communications come in and relationships to primary care. So this sector is sort of your leading edge, but you're depending on the other sectors, drawing on those resources to make it all work. You're looking at me like you're learning something, but I know you know all of this. I'm just trying to summarize it for everybody and for us to think about how to make sure that our functional abilities optimize what we have in terms of investments in capacity over time. If I were your Prime Minister or your Minister of Health or your Director of the NCDC, I would say our immunization level is inadequate, and we have to really pay attention to those points that you made. There is one of your points, though, concerns me, local production of vaccines. At a political level, this is a demand of politicians, and national pride is involved. But the danger is the production of vaccines that would be creating more hesitance than internationally authorized and known vaccines. And it could be a distraction from strengthening the primary care system and doing the communications and working with communities to use the vaccines that are already well known in the country. So in some sense, we have the public health implementation could be in contradiction to national pride or politics. And this is a delicate point. Many governments around the world, after poor access to COVID vaccines are focusing on producing vaccines. And there's the danger that we take our attention off of using the capacity that we have and maybe not producing the vaccines that will be high enough quality to enter the market or to sell. So we may lose our focus. There has to be a balance. But there's a danger of getting it wrong. So I agree with most of your scores, and I certainly agree with most of the actions that you say you need to take. But I wonder if you're as uncomfortable as I am about the underperformance of the system. I didn't see in your statements about the things that need to be done, the urgency, and the opportunity to reach 85 or 90% coverage among young children. I think on average about 4 die from measles in Nigeria. It varies a great deal year by year. But this is a crime because we have the ability to prevent that. So I think we have to think very strategically about where are the weaknesses and what will intervene to change them. And we shouldn't feel comfortable that it's, like many of the aspects of development, yes, we need more staff, yes, we need to improve the information systems, but the urgency of improving this can be the edge to make those things happen. And I only had a question about your score for the last indicator, 8.3. Let's get to the indicator. Yes, no, that's one. 8.3, good. National plans for mass vaccination, and I know you've been doing mass vaccinations for measles, including measles when measles coverage is low, including guidelines for regulatory approval and acquisition of new and experimental vaccines. I know this is moving forward. The point is that they are disseminated and implemented at all levels. I'm not so sure. I haven't seen the evidence, so I would like to have us meet on the side to discuss how much and how well they are disseminated at the intermediate and local levels. Let us take a little time on the side for that. If we can be convinced, fine. If not, I think you'll have to go down to a level 3 on that point. That's what I had for introduction.
So you have not a specific question, you only had a comment. At this moment you do not have a question. But
I had challenges.
But before going to the audience, I would like to give the Nigerian team to give their reply on the comments of the external team lead.
Thank you very much, sir, for your comments and then your observations. We were on a jet speed prior to the advent of the COVID-19 epidemic in terms of our desire to ensure an appropriate coverage for our routine immunization activities. When the next mix survey results of 2016 came out, the national average was at 33%. The executive director, in his wisdom, deemed that fit to accept and then put in place interventions that will ensure we jack up the coverage. And that was how we gave birth to the National Emergency Routine Immunization Coordination Center, which is NERIC, which oversees the activities of routine immunization. So from a low point of 33%, we rose to about 70-something%. But when COVID came, it crashed because there were competing activities, the stay at home and all that, and that impacted negatively on our service delivery system. And then we came down to about 57%. Now that COVID is just by the side, there's a renewed drive by the agency now to ensure that we catch up and effectively surpass where we were before. For instance, a lot of the poor performing areas of the country have been mapped out. considering areas where we have zero doses, the poor performing LGAs. They've been mapped out, and then we are in the third of a series of intensive routine immunization, intensive campaign to ensure that we catch up with the gaps that have been identified. And we are also not forgetting the zero dose communities, because of course, it's only clear with the diphtheria outbreak that most of those areas that are poor performing are the areas hardest hit by the diphtheria outbreak. So in addition to the routine immunization intensification exercise we are doing, we're also responding to the outbreak that is currently ongoing to ensure that we nip it in the bud and ensure that we continue to experience a steady increase in our routine immunization coverage, supported also by the supplemental immunization activities. We also talked about NEMCHIC, and an arm of NEMCHIC is CHIPS, the Community Health Influencers and Promoters Services. They also help a lot in identifying areas where we have newborns and then linking them up with health services so that we don't have missed opportunities for children born in communities. So these are some of the efforts that the agency is making to ensure that we not only catch up, but we hit the target and possibly surpass our target. Thank you, sir. I don't know if my colleagues have anything to add to.
Okay, thank you very much. Just to buttress the point he made as regards the impact of COVID-19, this is equally reflective in the surveillance data. Prior to the pandemic, the country has actually observed, or recorded rather, a decline in the body. However, following the impact of COVID-19, we kind of experienced an upsurge in keeping with the fact that perhaps the COVID-19 pandemic might have had an impact. But currently, we are working on updating the measles strategic plan. We are working on SIA's plan for hopefully next year, and we hope that by the time we put this together, we'll return back to the initial trajectory prior to the COVID-19 pandemic. Thank you.
Also, in addition to that, MPACD has stopped the issue of verticalization of programs. All services are integrated. So when you are doing a measles campaign, you go in and you deliver measles vaccines and routine immunization vaccines. You also deliver all the gamut of PHC services. And also, there's something you talked about, guidelines. We have operational guidelines, even up to vaccination team members. We have specific clear roles and responsibilities in terms of guidelines for what a ward focal person should do, the vaccinator should do, the supervisor should do, and even the house-to-house mobilizers. All these can be easily cited. Over.
So thank you very much for that wonderful presentation. I think you're doing a lot. I agree with the score for 8.1, that is the 2. If you go to priority areas, can you go to priority areas where you have local, good. So this local vaccine production, I encourage you to work on that. A little bit slightly differ from Richard on that, because if you don't start, you remain not to start. So, but you have to strategize properly to make sure that all the necessary preparations are in place in terms of communication. You communicate to the masses for them to understand, and there will be no hesitancy in terms of taking the vaccine. So I encourage you to go ahead.
May I turn to the external team? Are there questions to the Nigerian team related to immunization? You have no questions? Then I turn to the moderator for comments or questions from the audience.
All right, thank you very much, Prof. So we have 2 questions for now. Let's start with you, sir.
Thank you very much for the opportunity, and thank you for the team and the evaluators for their kind comments. I had to rise to speak on part of the comment from the lead evaluator regarding the desire for nations to look seriously at the vaccine production capacity in country. Part of the challenge we experienced in the time of COVID showed us that the equitable distribution of vaccines is something that we all must pay close attention to. While we recognize the challenges that are raised for Nigeria to make that drive, it becomes a thing that we also must not lose focus on. How do we ensure that nations that do not have in-country capacity and are producing the vaccines in-country are not left out in the times of emergencies? I think that is crucial, and I speak clearly because I come from an institution that has a 100-year history of vaccine manufacturing and production, the National Veterinary Research Institute, VOM. Unfortunately, situations will not allow you to go there. But I think beyond just national pride, Africa and nations in Africa must come to a point where we build these capacities and ensure that should there be outbreaks or pandemics that places health risks, we are not left out. And I think that is a clear message that the international community needs to recognize and to find a way how we can work together and be able to achieve that. Thank you very much.
Thank you very much. Great submission there. Where do we have the second contribution?
Thank you very much.
Just a comment that we all certainly agree.
All right. So congratulations to the Nigerian team on your presentation and to Nigeria and the efforts that they're making. I noted we all experienced the scenario for health service delivery when we have a pandemic that leads to lockdown. It has impact. But I'm not seeing, I don't know if you've considered it as part of our strategy going forward on how we can mobilize and continue to provide services if such a pandemic comes again, because it is projected that it would, and it may even come back to back compared to what we have. So we have a bit of a breather space from COVID-19, but going forward, and it would probably simply just look at the mechanism we already have for doing mop-up and see how we can mobilize that mechanism to provide services just in case we have a lockdown for any other pandemic. So I'm just wondering if we thought about that, and it's also part of our plan. Thank you.
Thank you very much, Ma. Also, quickly, last one.
Thank you very much. I'm Pharmacist Silas from Federal Ministry of Health. To buttress more on the local vaccine manufacturing, we at the Federal Ministry of Health, we've come up with the National Vaccine Policy in 2021, and it has been disseminated. And right now, the Ministry has formed a governing council for local vaccine manufacturing, of which a committee has been set up to draft a strategic plan for local vaccine manufacturing. And recently, the zero draft has been cleaned, of which we are awaiting the validation of the final draft. Just like the presenter said, the need for local vaccine manufacturing in the country is so very important, and the ministry deemed it necessary that federal government of Nigeria must shift focus from disease surveillance and immunization, just like consumer nation, to going into production of vaccine. That is why the strategic plan has been keyed into the policy of government, taking advantage of the vaccine, animal vaccine production in NVRI JOS, and the maturity level that NAFDAC is getting to have a hold on both import manufacturing of vaccine and local manufacturing, as well as the African Continental Free Trade Agreement that entails 60% of manufacture of local vaccine for routine needs of the continent. So Federal Ministry of Health is having a big hammer on the need for local vaccine manufacture. And we have gotten the blessing of Mr. President, which have encouraged United States Pharmacopoeia, WHO, to give us
a good helping hand, just like they are doing in Rwanda, Senegal, Kenya, and recently Ghana. And we hope that the encouragement from these evaluators will make Nigeria to focus towards that local vaccine manufacturing. Thank you.
All right, thank you very much. So I think we're back now to the evaluators for your submissions on this presentation.
I could not understand everything that was said because of some echo up here, so please let's have a little bit of talk afterwards. We see here overall in the question, again, measles vaccine is a wonderful X-ray onto the health system. You can see a little bit of everything that you need, and you see where we are at the moment. It's kind of like the pulse, which can change month by month and year by year. We have to have the vaccines in hand to distribute them. You also need to have the system competent to have the cold chain to reach people. And you also have to have the relationships with the community that are adequate so that vaccine hesitancy doesn't prevent the use of all that system. Vaccine hesitancy has been an issue everywhere, and it's not going away. It's growing. This in the end, could stymie all of our good efforts. We can build all the capacity if we don't have that last piece, that last mile piece has to do with our relationships with the community. That means communications and primary care. So we need all the pieces to be together for this to work well. Yes, so I propose that for indicator P81, we agree with your score of 2. With indicator P82, we agree with your score of 4. And with the third indicator, P8.3, we want to take it to the side to discuss how well and how much the implementation is capable at all levels before we could identify it as a 4. So for the moment, provisional 3.
You are saying we, but it is you are proposing it, and it becomes a we when the external team is concluding that they can follow you. So I turn to the external team and the co-lead. Are you in agreement with the proposal of the team lead on the scoring?
Yes, yes, yes.
And the external team, I see nodding. This means that the I became a we. So the proposal to you is a 2, a 4, and I think we are in consensus with this because that you propose yourself. Is that okay for you? And then on the third indicator, there is a provisional 3 where the team lead already is asking for a side event. So this means that there will be no conclusion at this moment for the score on the third indicator. I will kindly ask the Nigerian and the team lead and co-lead from the external team to go in a side meeting to try to reach consensus. You need to convince him and come back to the plenary as soon as you reach consensus. On the priority actions, I think you are in agreement, but you can discuss that as well. Side meeting. With this, I would like to thank you very much for your excellent presentation and defense of your presentation. And I also thank my colleagues from the external team. Thank you so much.
Thank you very much.
Thank you very much. Thank you very much. I think we can make it better for them as they get back to their seats. Thank you so much. All right, again, we've not heard the last from them until we have the consensus reached at the side meeting. We are still awaiting the outcome of the side meeting for the infection prevention and control technical area. I think it's been very tough inside the room there. They've been there for about 20, 30 minutes. All right, so we move on. But one thing I just want to also possibly bring up is the fact that Nigeria last had a census, population census in 2006. And ideally, we are meant to have another one 10 years after, which should have been 2016. We attempted to have it this year in May, but for the political issues. So I believe with our census conducted, the issues around having the right micro-planning done, proper coverage will be better determined. And I think it will also help us in other indices we may be looking forward to when we have the right population we are really working with, not just the projected population alone. All right, moving forward. So that should be happening very soon in the coming months, hopefully. So having said this, it's been very challenging to keep people's conversation at the minimum volume in the room. It's a lot of interference to the front. We really keep appealing to us. Let's keep our conversation, our vertical conversations very low with the pitch so that there will be minimal interference with the main proceedings. I beg you by the mercies of God. Moving on, we take the last but one presentation, and that is taking us to the point of entry, technical area. And to lead us in this conversation for points of entry and border health, I have from the Federal Ministry of Health, Dr. Fatima Mohammed Yusuf. A round of applause for Dr. Fatima, please, as she makes her way to the microphone. She will be ably joined by colleagues from the NCAA, and that's in person of Dr. Haggai Wilfred. Dr. Haggai, you're very much welcome. The interventions at the Port Health Service, distinguished ladies and gentlemen, has been ably supported and strongly supported over the years by our very dependable partner, ProHealth International. Representing this organization in this team is Mr. Olaholuwa Akinholuwa. A round of applause for him, please. I'm trying to look for him in the hall. Okay, I hope he joins them. Then also from the Federal Ministry of Health, we have Ms. Onyekachi Nweteze. Round of applause for her, please. So that's the Nigerian team introduced, and may I now yield the floor to the external evaluators for their introduction of the composition of this team, who is taking the lead. Then we can go to the business of the conversation. External evaluators, please. External evaluators, we will be ready when you're ready. All right.
Thank you, Mr. Moderator. We are now going to the points of entry. So I want to introduce the external team leads by themselves.
Okay. Yes, so I don't know how many times we should introduce ourselves. I'm Buba Manjang from the Gambia.
Thank you very much. I'm Nyamazana Catherine from Zimbabwe. Thank you.
Thank you so much. This is not our last technical area. There will come on one more, and I fully understand this will be more and more difficult, but I kindly ask your attention. When there is a lot of noise coming, for us it will be very difficult to understand each other. So we have only 2 to go. And now for the points of entry, I kindly ask the presenter to start their presentation. Good luck.
Okay, good afternoon everyone. This is the points of entry pillar, technical area. The points of entry technical area is a multi-sectoral technical area consisting of Port Health Services, Federal Ministry of Health, the Nigerian Civil Aviation, Federal Aviation Authority of Nigeria, NAQS, Immigrations, Customs, and so on and so forth. So points of entry as defined as the IHR, which you already know, entry and exit points for in and out of the country, and Port Health Services is the competent public health authority at the point of entry. It was created in the year 1926. It's one of the oldest agencies in the country. Port Health Services currently mans 66 points of entry, 51 ground crossings, 10 seaports, and 5 international airports. Of this points of entry, we have 3 airports designated, and that's Lagos, Abuja, and Kano. And then we have the Apapa Seaport, Lagos, also designated. These are the POE stakeholders, NIMASA, NAMA, FAN, and so on and so forth. And so for points of entry, we have 3 indicators. The first indicator is core capacity requirements at all times for points of entry. And for this indicator, we scored ourselves at 4. All designated points of entry are implementing routine core capacities with an all-hazard and multi-sectoral approach. The rationale for this scoring is we have the presence of ambulances and trained personnel for transportation of suspect ill persons at all designated points of entry and some non-designated points of entry. We conduct regular inspection programs, including joint inspection programs with all other agencies at the points of entry for food, safety, water, washrooms, conveyances, and vector control. There's regular capacity building for personnel on vector control, inspection, assessment of suspect ill persons, IPC measures, and emergency response. And also, we have a comprehensive inspection and supervision tool. So, the strengths and best practices. For our strengths, we have strong collaboration between POE and other points of entry agencies on implementation of routine core capacities at designated and non-designated points of entry, joint inspection programs, as we have said. We did a multi-sectoral development of the National Port Health Policy. We've evaluated, our multi-sectoral approaches using an after-action review for COVID-19 and other real-life events like the Marburg suspect cases in Port Harcourt Airport recently. For best practices, we have primary screening of all passengers passing through points of entry. We have secondary screening of suspect ill persons. We elicit information concerning travel histories, symptoms, verifiable contact details, location in country, and so on. And we have referral of suspect ill persons to designated medical facilities, and we also have MOUs with some of these referral facilities. Also, we report through the IDSR and the SOMAS platforms. We conduct regular inspections. Also, we do water sampling and testing of food handlers at designated points of entry and some non-designated points of entry. IHR assessment has been done for core capacities have been done at all designated points of entry and including a non-designated point of entry, which is the Semi-Krake Joint Border Post. Technical support for capacity building, supervision, and development of a review of relevant documents from partners. Also, we do monthly fumigation, geratin, and other vector control measures. There's a strong linkage between PHS and medical facilities, and also diagnostic facilities, as was witnessed during COVID. We have developed the Port Health Services Implementation Guidelines document. The document contains all PHS SOPs and case definition of IDSR priority diseases. PHS has instituted the master training program. The MTP curriculum is currently being adapted by other African countries. It's currently being adapted by all of the West Africa, Central Africa, and Ukraine. Training on issuance of ship sanitation certificate. 8 of our 10 seaports have finally been authorized to issue ship sanitation certificates. This is the first time in Nigeria's history. Okay, and then areas that need strengthening. Why there's linkages between the radiological and the chemical areas, we also still need to strengthen it and ensure that point of entry pillars are incorporated in all of the relevant documents. We also need to build human capacity and improve human resources for health. Also, we need provision of equipment and necessary for implementing routine core capacities, especially at non-designated points of entry. And then we need to review our guidelines and SOPs post-COVID. Also, we need to digitize the PHS activities such as issuance of waivers for the repatriation of human remains. Our challenges include inclusion of POE into the routine reporting for chemical and NRA, inadequate human resources, and inadequate holding areas for isolation at non-designated points of entry. For indicator 2, we scored ourselves 5. I know. The rationale for this scoring is that the point of entry and border health pillar has developed a national public health emergency contingency plan in alignment with all national emergency plans and alert codes. Also, we have developed a multisectoral POE-specific PHCP for all designated points of entry and some non-designated points of entry. We have 18 PHCPs for POE specifics. We've also integrated the POE-specific PHCPs into the National Public Health Emergency Contingency Plan, as well as POE-specific multi-hazard plans, such as the Aerodrome Emergency Plan for airports and the Port Emergency Plans for seaports. There's presence of ambulance and trained personnel for the transport and referral of suspect ill travelers at all designated points of entry. These are our strengths, as we said: multi-sectoral collaboration, 18 PHCPs developed, 13 for non-designated, and 4 for already designated points of entry. We've digitized data collection and collation at all international airports during emergencies, like the NITP portal. We've been able to activate and reactivate the PHCP during emergencies. Activation level of the POE-specific PHCP during emergencies are at the POE level. We've also had collection of passenger data for contact tracing, use of the developed SOPs and protocols for response to all public health events at points of entry, and then referral of suspect ill persons. Also, we've conducted risk communication for both POE and border communities, cross-border collaboration for surveillance and information sharing between Nigeria and neighboring countries. And Nigeria inaugurated a national cross-border committee and conducted a multilateral meeting with all 4 neighboring countries. And also, POE has been integrated into the National Public Health Emergency Multi-Hazard Plan, and also the Pandemic Influenza Plan, amongst others. Also, we've conducted the contamination and disinfection following response to public health emergencies using developed SOPs. And there exist MOUs between POE and some health facilities. There's regular communication between the Department of Public Health, FMOH, state epidemiologists, and NCDC during emergencies. So, challenges: inadequate human resources, again, inadequate holding and isolation areas. Some points of entry have to use their secondary screening areas for isolation areas at some non-designated points of entry. And then the use of one database. So we're proposing the use of maybe the immigration database, which is the MIDAS platform for collection of data, since PHS and immigration collect similar data to passenger biodata. Indicator 3, we also scored ourselves for 5. This is a new indicator, and the rationale for this scoring is that we've been using the entry and exit guidelines and protocols developed by the POE pillar of the Presidential Steering Committee as evident during the COVID-19 pandemic and polio response, the use of the NITP for COVID-19 pandemic response, and integrated POE-specific PHCP into POE multi-hazard plans. So the best practices: we have the regular cross-border forums at some ground crossings with neighboring countries. We have the deployment and management of quarantine measures during outbreaks as evident in COVID-19. We have the issuance of the ICVP, that is the e-yellow card, which was launched in 2018. We also have the NFEC POE meeting, which is the National Public Health Emergency Response Committee, constituted by the National Public Health Emergency Contingency Plan for the development and review of travel and quarantine protocols. We use coordination mechanisms such as the PSC and the PTF for travel-related health measures. Also, there's compliance from all other agencies and collaboration. We did a population mobility mapping recently for Marburg outbreak from Equatorial Guinea at some of our seaports, and even a state with no seaport. And then the challenges: there's delayed compliance to agreed public health measures by some conveyances, operators. There's moderate compliance to the travel-related measures by passengers, as witnessed in the COVID-19 entry and exit testing protocol. And the draft MOU for cross-border collaboration has not been reviewed by neighboring countries yet. Also, as we said, expansion of the digital portal, that's the NITP, to include both the seaports and the ground crossings for data collection. So priority areas for action: we have the development of SOPs for response to chemical and radiological hazards. We have integration of points of entry into radiological and chemical surveillance systems, and we also have the review and updates of our PHS SOPs and guidelines post-COVID. We also need to review our MOU with neighboring countries and establish cross-border forums at other ground crossings. We also need to strengthen collaboration and coordination with POE stakeholders, public health assessment of some non-designated points of entry to determine which public health capacities are needed at each. We also continuously train staff and other frontline agencies to strengthen human resources for more effective implementation of IHR core capacities, equipment and infrastructure such as ambulance and holding areas to non-designated points of entry, digitization of POE tools and expansion of the NITP portal, development of diagnostic and testing capacities as designated points of entry, and then harmonization of data collection platforms for port health services and immigration. These are our supporting documents. Other supporting documents for water safety, water analysis, food safety are all available at the points of entry. This is also part of our supporting documents, and these are the POE team members. Thank you very much.
Thank you very much. Point of entry and border heads. Evaluators, over to you.
Okay. Thank you, Ma, for that presentation. You're doing a lot, of course. Can you go to the priority areas that need focus?
Okay.
Yes. Okay. Development SOPs, review, okay, cross-border, and then public health assessment. Is that all? Do you have some? Yeah, let's go. Okay, trainings, equipment, okay, digitalization and the like. Okay, so, yeah, well done. Nigeria is doing well, you know, so, but I think we need to look at some areas, if you agree with me, what could be done for that? First of all, we need to look at all hazards. Talking about all hazards, I've seen biological, you're doing well on that. How about chemical and radiological? Yeah, we need to look at that. If I can add that to the list, we look at chemical, radiological aspects so that we can have all hazards. Yeah. Okay. So we also need to look at the points of entry. Yeah. Is highly needed in terms of referral and the like. We need to have maybe a station ambulance there so that suspected cases are transported in a special way.
We have that.
Yeah, I'm happy you have that. Thank you, ma'am. At the same time, we also, yeah, the human resources. Human resources. I'm seeing it here frequently, inadequate human resources. Maybe you can explain to me what do you mean by that?
Okay. So generally, Nigeria has a staffing problem. At points of entry, it's more pronounced. In the last 3 years, Port Health Services has had to rely on such capacity to continue implementing screening protocols at points of entry. Would like for us to have sustainable workforce and a larger workforce base for points of entry.
Okay. So another question is, do you have coverage for all the POEs, including undesignated POEs?
Absolutely. We have point of entry staff at all 66 points of entry in Nigeria that is manned.
Yeah, that is fine. So how about the resources, the consumables that you might need at all these POEs? Is it sufficient enough for all the areas?
Sorry, I didn't get the question.
The consumables, the gadgets, the material resources.
Okay, consumables and supplies.
Yes.
Let me give this question to my director.
Okay, thank you very much. We have a supply chain of consumables. We do.
Let me add to this. Naturally, across 66 points of entries and across the kind of landmass you're looking at for Nigeria. We have one of the longest borderlines in the region. Across this general diversity of situation with the point of entry, you would expect that there will be some logistical difficulties, but we have a consistent supply of supplies to all the points of entries. Portal Services receives, through collaboration with other stakeholders, a steady supply of consumables from NCDC, from other partners, the Federal Ministry of Health, WHO, IOM, ProHealth International, funded by the United States Center for Disease Control. There is a steady supply of consumables monitored by a central inventory system at the Federal Ministry of Health.
Yes, thank you so much, my brother. Yes, so the other thing I want to add is about the cross-border collaboration and also review of making reviews in terms of simulation exercises or review of some the contingency plans, various plans for the POEs. I don't know whether you review them or not. So can you explain that, Ma?
Yes, we review them. All PHCPs that were developed before COVID were reviewed last year, post-COVID, and they were reviewed in an all-hazard manner. Thank you.
Just to add to that, we don't just review, we test. We don't just test, we do full-scale testing. In fact, we've done testing at the designated points of entry. One of the cases, we had to actually plan somebody from another country to come in to test the system. And most of it is done between the regulator and the partners, not with Port Health. Port Health are not involved in the testing. We actually surprise them. We plant people in the aircraft and the seaports to come in, and the land ports to come in to test the system. So this has been done, and we have documentation at the points of entry.
Thank you so much. So well done. Can you go to the results then? The score. For indicator one, huh? Okay, good, you are there. So, we look at the priority areas, and then I was thinking we add the chemical aspects and also think of the ambulance issues, isn't it?
I'm sorry, I didn't hear you.
I mean, we are just from looking at the priority areas, isn't it?
Yeah.
So, we discussed about the issue of ambulance, to have station ambulance for referral.
Yeah.
And also we talk about all hazard issues that is not completed, The radiological and the chemical aspects are not integrated into.
They are included.
They are there.
Yes, they are included. They are always included. The only challenge is we don't have a standard SOP for operating, and that's what we want to develop.
But
they are included.
But they are there.
Absolutely,
Thank
always.
You. If that is there, I leave the first score there. Can you move? Can you move?
Okay.
Yes. Oh, okay. I'll maintain the 4 provisionally. So, but let me ask from my.
Thank you very much for that brilliant and wonderful presentation. I have, maybe can we go to slide on indicator 1 where you're talking about challenges?
Okay.
So on that slide, I'm concerned about the challenges that you have put up. You're saying you need to include inclusion of points of entry routine reporting on chemical and radiological events. Can you confirm that is a challenge with you within the ports of entry?
Okay, so upon discussion with the NNRA, that is the agency responsible for radiological events in the country, they told us that they have their own specific surveillance system. And then we were like, oh, we would like to be part of your surveillance system, even though we report already for radiological hazards, but we want to be in your own surveillance system. And they were like, sure. When we're reviewing it, we're going to include the point of entry pillar. They already discussed with FAN. The conversation is already ongoing. FAN is also one of the agencies under points of entry. So this discussion is ongoing. We already have the linkage. It's based on this linkage that we found out that they have their own surveillance system that we want to also be part of. So that's just what we want to do. That's why we highlighted that as a challenge.
Okay, so we all agree that there is a challenge on that part. Then the other issue is inadequate resources is one of your challenges, as well as inadequate isolation areas for quarantining. You have that challenge within your port of entry, right?
At our non-designated points of entry, some, and not all, there's some non-designated points of entry also have holding areas, while some have to rely on their secondary holding facility, their secondary screening facility as their holding area. That is not best practice, so we want a separate holding area, and that's why we highlighted that as a challenge.
Okay, thank you. We can also move on to the second indicator.
Okay.
Where you're talking about your challenges as well.
Okay.
You mentioned poor linkage, again to responsibility of radiological and chemical events. Confirm that is the position.
Yes, it's the same thing. Like we said, it's not standardized. While we have these processes, we want it standardized so that even if we leave and new people come in, there's already an SOP that they can always, work with.
Okay.
Yes.
Let's also move on to indicator number 3 on the challenges of that area.
Yeah.
And this is a new indicator. In 2017, you were not evaluated on this one. Confirm?
Yes.
Okay. So your only challenge on this one is delayed compliance to agreed public health measures. Confirm that's a challenge you're having?
We had that challenge at the start of COVID when we started the testing upon entry into the country, 72-hour testing. Some airlines, some conveyances at the borders were not complying, but for the airports, NCAA stepped in and started to find airlines who were not compliant, and then the compliance levels went up. But then we want to ensure that this compliance level stays up going forward, and that's why we put it as a challenge. It's a challenge for us. We must ensure that we're always at 100, and NCAA cannot.
Yeah, just to throw some light on this, when we say moderate compliance, compliance to travel-related measures worldwide was a bit of a challenge to most countries. Nigeria is not exclusive because of the different protocols from different airlines and different, but we had a very good way of managing it. Right now we have actually a WhatsApp group at each POE, a WhatsApp group that consists of every airline and every operator with all the agencies on that WhatsApp platform. And we send the messages for this on that platform. So if there's a non-compliance, the WhatsApp group created for each FEMT, we call it Public Health Emergency Management Team. For every point of entry, we have a Public Health Emergency Management Team, and we have a WhatsApp messaging system that coordinates all these systems. So this moderate compliance was actually activated during the COVID-19, and we had a good working relationship with the airlines. Thank you.
Thank you very much for acknowledging that there are challenges, and I appreciate the explanations. Thank you.
Are there others from the external team who have comment? I turn back to you. You proposed already a score for the first indicator, or not yet? Yes. You propose?
For to be maintained.
So before going forward, as we are talking in this area about proposals of high scores, and I'm here as the defender of the global tool, I would like to say, because this is for any country in the world, when you want to reach a high score, when you want to reach a score of 4, doesn't matter in what technical area, there needs to be a demonstrated capacity. Attributes are in place and sustainable for a few years and can be measured by the inclusion of attributes of or IHR core capacities in the National Health Sector Plan and a secure funding source. That is needed in general for 4. For 5, in general, it is needed to have sustainable capacity. All attributes are functional and sustainable, and the country is supporting one or more other countries in their implementation. This is the highest level of the achievement of implementation of IHR core capacities. This means, and this is not only for this technical area, this is for all technical areas. If you want to achieve a 5, you need to show that you are assisting other countries in implementing this technical area. If you are not doing this, then you cannot get a 5. So this more in general. I will not go into the details of this technical area because therefore we have our team lead, our technical area lead.
Thank you very much, Hans. Ma, I think the score for 4 is going to be maintained, but because I asked you, you said, yes, we have. You have all those things. If you have them, fine. You need to show us as a proof, then the 4 will be maintained. The fact that you say you have, so we maintain it. But if you don't have, definitely, we cannot give it to you. So we go to indicator 2, where you score 5. So are you sure? Are you comfortable with the 5? Or because I'm seeing certain things I have to explain. There are some gaps that need to be fulfilled. So tell me, are you comfortable or not?
Let me just say, as defined by this, the wording here, we score a 5. We understand that we are open to significant improvement, but as defined here, we do score a 5, including some of the elements that you mentioned just now. Nigeria plays a significant role in the region in terms of supporting cross-border collaboration activity, not just with our neighbors. I don't know if Kachi mentioned earlier the training, capacity building efforts Nigeria has made in developing border health training materials for the region. But I believe that if stepping the scores down signals a capacity for development, a room for improvement, we're happy to do that, or I am happy to do that.
Okay, just to add to the assistance within the region, our protocols actually during the COVID-19 played a lot of role for many other countries to tailor into. And we also were involved, especially in the aviation sector, to develop the African Union capacity and competency technical assessment report, and also ECOWAS. We were involved in those discussions at that level. So the AU had a high-level meeting that had to do with the COVID-19 protocols. We worked under the technical area and also ECOWAS. So regionally, we have been of assistance, and our protocols also was helpful to some of these countries around us. Thank you.
Okay, thank you very much. So, to be honest, looking at some of the gaps that we have, to be candid, I think we move these to, with due respect, we move these to 4, so that, yeah, I'm giving it to them, so that we'll be able to have room for improvement, with due respect.
Before applauding, we are not already there. I need to reach consensus in the external team first. Co-lead, what do you think?
Thank you very much. So I'm not sure how you address this, because level 4, it's requesting you to be able to to be able to actually monitoring and have a capacity for all hazards. And this, in this instance, you said on the list of your challenges, those challenges you put across, you mentioned challenges with all
Sorry, can we
hazards.
have the screen?
So I'm not sure if you can score 4 when you still have challenges to all hazards. You are, on other hazards, yes, you're okay, but on chemical parts, so I don't know how we can then say you are at level 4. Maybe if you can explain how you want to manage that.
So I think the logic behind that is that the contingency plans that we have at the designated points of entries and some non-designated point of entries are designed to respond to all hazards. So as an example, the incident management system for those contingency plan is such that there is a response manager per hazard, or as it is called in the Abuja airport, an on-scene commander. So if we have an animal health related emergency, like the current anthrax outbreak, the NAQS lead for that point of entry takes charge. And if we have a chemical event, the relevant stakeholder takes charge. So the contingency plans itself is designed to be multi-hazard and to respond to all hazard. There is a incident commander and then a response manager that is hazard specific. So that's the design of the instrument itself. And what we have identified there is ensuring that we continue to build capacity, especially in the other hazard areas, chemical and radiological, to ensure that we're able to respond to those effectively, and that we have a routine reporting system for them.
Okay, thank you. I'm not sure. Okay, a day before yesterday, the chemical events group, they scored 2 on chemical events, and you points of entry, you're now scoring a 4. You're more than what the experts in that area scored. I don't know.
To the external team, this is important because these are no stand-alone technical areas. They are in combination with each other. And it is a very rightly said point. And if I understand you well, you are saying because chemical events is scoring a 2, you think on this point, in this indicator, you should propose a 3. Yes. So now we have a point of discussion. In our external team, the lead is proposing a 4 and the co-lead is proposing a 3. You've heard the arguments. You can even propose what the Nigerian team is proposing, a 5. So I'm looking to the external team and I say first, who is in favor of a 5? I see one nodding yes. I see no nodding yes. Who is in favor of a 4? Who is in favor of a 3? Yes, I see a majority. This is not a bargaining tool. This is on explanations as the events on chemical events and what they do to this tool. So I turn to the lead. The co-lead and the team are proposing a 3. What are you?
Yes, I'm proposing 4, simply because these are different thematic areas. You have chemical events. No, I'm coming. I don't finish. So I'm proposing 4 anyway, because based on the fact that they are different thematic areas.
Okay. Now, as a team lead, I have to decide either to follow the team lead or the team. And I would propose to the team to follow the team lead, as he is the lead and he has prepared. So if you are in agreement that we follow the team lead by proposing a 4. This means, as you have seen our internal discussion, that our internal discussion is between a 3 and a 4, but we are not discussing a 5. So I'm asking you, are you in agreement with a 4, or are you in disagreement with a 4?
Yes, we are in agreement with a 4. We are not in agreement with a 3 because level 4 speaks to public health emergency contingency plans for events caused by all hazards. It speaks to the plans itself. And we have all our public health emergency contingencies plans speaking to all hazard components. So this is why we are okay with stepping down from a 5, but we are okay with a 4.
Thank you. So I see that now we don't even need a side meeting. We have consensus on a 4 for the second indicator, turning to the third indicator.
Yes, going to the third indicator, you score yourself, can you go there? You score yourself 5, huh? Okay. What public contingency plan? Okay, this is the third one, okay. Okay, country has conducted at least one review exercise, evaluation, actual event of exercise, national. So, are you comfortable with this? This exercise is conducted, and then you update it in the strategy? Yeah. Are you sure? Okay. I will not give you score. Let me give you to my core first.
Okay. Let me add some more context to this. In the last year, there's been simulation exercises at a national level and also at point of entry level to test multisectoral strategy and collaboration in response to public health events at point of entry and in response to implementation of travel health measures. We have also done an after-action review. There is, as Onyekechi mentioned earlier, a national committee for response to public health events at point of entry that met at the beginning of COVID and formed most of the policy and the travel-related protocols before the constitution of the Presidential Task Force. That committee met again last year to review its guiding document, the contingency plan, and is built to meet again this year, in fact, in a few days' time. The idea is that the committee meets during events rather regularly to form the policies around border entry, border health, and to guide the implementation. And so we believe that the meeting of that group, the exercises done, the after-action review constitutes enough ground to be here. But again, we're open to discussions.
To also add to that, travel-related measures would be focusing on measures that are taken at points of entry to stop the spread of infectious disease. The measures should be taken at both passengers, baggages, conveyances, and so on and so forth. The issuance of the ICVP, which is the yellow card, is the travel-related measures in line with the I strategy. That is the elimination of yellow fever strategy, eradication of yellow fever. And also the issuance of waiver to human remains entering the country is also a travel-related measure which was instituted by Port Health Service to ensure that corps coming into the country are not infected before entry. So these are also travel-related measures that are being updated with time.
May I ask you a question? Is this also in relation to animal health trade of live animals? Can you explain a little bit about this? Because this is a very high level. If you look at this, with the trade in live animals, and there are trade-related issues on animal diseases, for example, foot and mouth disease or avian influenza.
So we work very closely with the animal health So we work very closely with the Nigerian Agricultural Quarantine Service, which is responsible for animal and plant and agricultural products at the border. They are a part of the national coordination mechanism, also a key part of all point of entry coordination mechanisms. I believe they have staff and, okay.
Sorry, the NAQS would like to say something on that.
Someone is standing with the mic, please.
Yeah. NAQS, we have surveillance for all the ports. They are all intact.
Speak about.
Please, can you repeat the question? Please, can you repeat the question so that she can...
May I will repeat my question. This JEE is multisectoral. It is One Health. It is not only about human health and about trafficking of humans. It's also about live animal-related transboundary animal diseases. So it is about avian influenza. It's about foot and mouth disease. And all the measures that are taken for humans, are they there? Is the capacity the same for the animal trade in live animals? Can you prove that there will be no trade of live animals over your borders or into your borders when there is a transboundary animal disease in a neighboring country or in your country?
Yes, like I said before, we have our officers on ground to monitor what goes on in the borders. So there's enough surveillance on that.
Let me just add to, can I just add to what she said? Excuse me? Can I just add to what she's saying? Okay. Now, the Nigerian Agriculture is a federal government agency in charge of animal health. They are positioned at the point of entry, especially designated point of entry. They are part of the synergy in terms of overseeing the transportation within or exportation of animals within the point of entry. Now, they have holding points in some of these point of entry, especially in Kano and Lagos. So they have their holding points and they have their own, and they are part of the pitch SECP, they're part of the FEMT at the point of entry. We work together, and that's why they're here as part of the partners and the stakeholders at this meeting. So they are a part of is a One Health discussion that we have at the point of entry.
So, but let me just emphasize that, again, as across the country and as across the world, there is a lot of room to grow. We recognize that. And in a recent meeting where I was, we emphasized the fact that we need a lot more presence from the animal health in the coordination mechanisms at point of entry. So we recognize that, but the structure is in place for them to what is required. And we have, okay, I would just stop there.
Okay.
Okay.
Are you done?
No, NAQS want to add something.
Yeah, good afternoon, please. All protocols duly observed. I'm Dr. David from NAQS, and that's Nigerian Agricultural Quarantine Service. So we are actually a regulatory agency under the Federal Ministry of Agriculture that are mandated with the prevention, control, and spread of exotic pests and diseases of animals, plants, and aquatic resources. So we are actually positioned in all the international points of entries. So the international land borders, we have officers that man those points 24 hours. So at any given time, when animal products are coming in, is it plant products or aquatic, there are officers on ground to inspect, verify before discharge. And in cases where there are issues, we have holding facilities, not necessarily in all of them, but we do have, and at times we take them to our central holding. We have one in Sheda in Abuja here, we have in Kano, we have in Lagos too. Thank you.
I can go ahead, huh? Thank you, ma'am. Okay, so, yes, we heard you, but like, there's somebody want to talk?
Yes,
carry
so
on, ma'am.
just to add to what the NAKS person said, there is a case of anthrax in Nigeria presently. It's an animal disease, and the NAQS is working at the border currently. I work with her in that, and there is huge surveillance at the border currently for anthrax disease. And they are also having these testing done at the border for the animals as well. Apart from the testing, there is a vaccination protocol developed ongoing, and also that is also going on, and not just in country, at the borders as well. Thank you.
So, okay, thank you very much. Considering the multisectoral strategy aspect, again, with due respect, we need to move these to 4. Tell me if you agree.
So I have to take over because you are proposing to the Nigerian team, but first you have to ask consensus in your own team. So I turn to the co-lead. The lead is proposing a 4. Are you in agreement?
Thank you very much. Okay, I'm not sure, but there is something that I just want to get confirmation from the Nigerian team. So the 5, it means that you have all the attributes for that indicator, and it's saying functional and sustainable, and the country is supporting one or more countries in their implementation. It's not saying the country will be supporting one or more country later. It's saying you are doing it right now. You are supporting one country, and then this is the highest level of the achievement of implementation of IHR core capacity. So my question to you is, are you... All right, okay, just take note of that. Thank you, I'll pass.
Okay, no response. Oh, okay. No, but
Are you in agreement with the leads proposing a 4, or are you proposing something else? Okay. So I turn to the external team. The lead and the co-lead are proposing a 4. Are you in agreement, or are you in agreement of a 5? So you are in agreement with a 4. So now I turn to the Nigerian team. The external team is proposing on the 3rd indicator of point of entry the very high score of 4. Are you in agreement with this?
Absolutely, we are.
You are wonderful. So I see now that there is consensus on the scores. There will be assigned priority actions according to your priority actions and the discussion we had. I would like to thank specifically the audience for their comments and for what they brought to us, specifically on the animal health sector. That was very helpful. And with this, I thank the Nigerian team. I thank our external team leads and co-lead. I thank you, and I close this technical area. Thank you.
Thank you very much. Thank you very much. All right. Thank you very much, everyone. Please, can we have a decorum? All right. Just like it's been said, it seems there's a lot to celebrate from the POE team. Okay. So just as been said, the theme of external, can we have one house now, please? I feel Friday will be a good time to really celebrate when the team is back from the field and all the relevant information provided there has been well validated, and collectively as a country we'll be glad to celebrate the outcome and much more celebration. So let's still keep that for now, but it's good to rejoice now for the work done so far. So we will be moving on to the last presentation for these evaluation assessments, and that is to bring forward radiation emergency technical area. And for this team, we have the lead from NNRA, Dr. Ali Mohammed Jida. A round of applause for him as he makes his way to the microphone. He will be supported by another vibrant officer from the agency, Madam Eze Ogechi. Eze Ogechi, a round of applause for her as she makes her way both to the high table. We will be yielding the floor to I think the external evaluators are also getting ready. So again, the weather is changing outside. It's raining, it's a bit windy, but we assure you everything is under control and we will have a safe landing. So let's have the last, okay, when the evaluators are ready, we will be having the introductions. So I now yield the floor to the external evaluators for the introduction, and we can move on with this proceeding. You have the floor, team lead, sir.
Thank you very much, Mr. Moderator. So this is our final chapter. There is still one technical area is in a side meeting, not having reached consensus. So we can only go to lunch when we have consensus on everything. So I asked already what is the status there, but we have to wait for that. And for now, our lead in this is, I don't ask them to introduce themselves again. The lead is Catherine from Zimbabwe, and the co-lead is Fischel from Liberia. With this, I would like to give the floor to the Nigerian team for your presentation. Thank you.
Thank you very much. Without following any order of protocols, please permit me to say good afternoon to you all. Good afternoon. My name is Ali Mohammed Jida. I work for the Nigerian Nuclear Regulatory Authority under the Division of Emergency Preparedness and Response. And here with me is my colleague, Ms. Ogechi. She also works with me under the Division of Emergency Preparedness and Response Division of the Nigerian Nuclear Regulatory Authority. These are just the abbreviations used in the presentations. And the NNRA has been designated as the technical lead for radiation emergency. And this organization was established by Nuclear Safety and Radiation Protection Act 19 of 1995 as the responsible competent authority for nuclear safety and radiological protection regulation in this country for all activities and facilities involving the use of nuclear or radioactive materials. Why? Is to ensure the protection of life, health, property, and the environment from the harmful effects of ionizing radiations, while allowing for its beneficial purposes, which cut across the research reactors or nuclear industries, oil and gas sectors, the medical sectors, where we have the hospitals, and some medical facilities, the construction companies, manufacturing companies, as well as in areas of research and development. Having said that, and looking at its beneficial purposes, which cut across some sector of the economy, there is still every possibility that accidents involving nuclear or radiological material will occur. That is to say, radiation incidents, and radiation emergencies. And these emergencies could either be a nuclear security event or a nuclear safety event. Nuclear security events in the sense that where we have terrorism, which might involve the use of IND, which is improvised nuclear device, or the use of RDD. It could also be the result of sabotage or theft, or either loss or missing of radioactive sources or nuclear material. And for nuclear safety, it involves either overexposure of workers or the public as a result of maybe daily activities. So these are some of the stakeholders. So if there is an emergency, and depending on the magnitude of such an emergency, stakeholders have been identified, and as the response organizations, as indicated in the National Response Plan. We have a National Response Plan which actually spells out the clear roles and responsibilities for over 40 organizations, what these organizations should do in case of an emergency, that is when an emergency is activated. So these are just overviews of the relevant stakeholders. And this is an organogram that shows how these organizations communicate to each other during nuclear or radiation emergencies. So straight to the point, the first indicator is whether there are mechanisms established and functional for detecting and responding to radiological or nuclear emergencies. One of our strengths is that we have a well-developed legislative framework. We have we have a total of about, as a country, we have a total of about 26 regulations, guides, and documents that actually guide those practices I listed in the course of my introductions. And we also have a plan for multisectoral, just like I said, this national plan clearly spells out the roles and responsibilities of those organizations, what to do and who is to do what, in order to avoid what is very common, conflict of interest. So one of the best practices is that there is an improved communication and collaboration as well as coordination between the NNRA and the IHR focal point. Then guidelines and SOPs have been developed because this national plan is a conglomerate of all the different SOPs from these stakeholders that were put together, reviewed together, and validated by these stakeholders, by the head of these stakeholders, to produce a document called the National Nuclear and Radiological Emergency Response Plan. And we've established, which is the newest activities, West African Nuclear and Radiological Monitoring Detection Response Center. The objective is to, or the aim is to have these stations at every geopolitical zones, but not within the town. Most of these stations are installed at the borders of our countries. So one has been installed at, what's the name of the place? Cabo local government area in Kano State. And the next phase, in the next 1 month or two, we'll be heading to the southern part of the countries, and gradually we are going to cover the country. So one of the importance of having this monitoring station, though the control station is located at the head office. Unfortunately, the picture is not here, but we've actually submitted the picture as part of our supporting document. So one of the objectives is to have a monitoring stations, because an emergency in country A is an emergency in country B, C, and D. Experience from Fukushima accident, Chernobyl accident, 3 Mile Island accident. So we need to have those monitoring stations in case the radiation drifted into our country. We should be able to have a timely and effective response to these radiations. I don't know what is happening. Sorry, I think maybe radiation is affecting it. So Nigeria has also registered its capabilities under the Response Assistance Network. So this Response Assistance Network is an offshoot of the conventions Nigeria as a country have signed, which is the Convention on Early Notification, Convention on Assistance Convention in case of nuclear or radiological emergencies. So these are the capabilities we have. Should there be an emergency in other countries, neighboring countries, Nigeria could be called upon to render these services. And if there are other emergencies, for instance, if there are emergencies in Nigeria that we don't have such capabilities, because we are signatories to these 2 emergency conventions, we can as well notify, as well as request for this assistance, because we've signed these 2 conventions and ratified the conventions in 1990. So some of the areas that need strengthening, I think most speakers have talked about budgetary provisions. So the NREP is operational, but in order to have an effective operations of this NREP, we need to have a budgetary, enhanced budgetary allocation across the stakeholders, and as well as across the 3 responsible organizations that have the authority to activate an emergency, which is Nigerian Atomic Energy Commission, the National Emergency Management Agency, which has been designated as a national authority for emergency in the country. So, and one of the areas, again, is the improved collaboration between the NNRA and the health-related MDAs for planning and implementation of training of human health workers. Though we've been having trainings across all the stakeholders, but we need to have some specific trainings for human health workers as regard to how to handle radiation injuries, because this is something that is, though we've not had any serious cases of radiation injuries or radiation accidents in the country, but as part of a preparedness arrangement and capabilities, we need to have all these in place, because if you have these in place, because they say, he that fails to plan will plan to fail. And then create opportunities for testing the relevant and policies and plans for nuclear and radiological emergency response plan, collaboration with NCDC as well as the Federal Ministry of Health as regard to the training of case managers. Then some of the challenges, though we put these as challenges, but these challenges, we have to look at it from a broader perspective. So definitely challenges will be there, but to what extent are those challenges? What are the effects of those challenges? So with these challenges, activities have not been hampered. Activities are still ongoing. But in order to have sustainability and to move very fast, we decided to bring this as part of the challenges. But activities are still ongoing. So for this, we are not thinking, but we felt we should be at level 4. Because we've actually, based on the contextual questions, we've actually achieved most of the activities in level 3. And the rationale behind it is that the country has an updated national response plan, and this response plan has been in operation. But as it is now, we are also updating the national response plan. It is a living document that needs to be updated as a result of lessons learned in the country, lessons learned outside the countries, as well as lessons learned from the reference document that were used to develop such document. One of it is the GSR Part 7. This GSR Part 7 used to be GSG2, but as a result of some nuclear accidents like the Chernobyl, Fukushima accident, it was reviewed to GSR Part 7. So we also definitely need to update the national plan to be inconsistent with the GSR Part 7, which is the Bible for emergency preparedness in the world. And the authority responsible for radiation surveillance monitoring in the country. Just like I said in the introductory part, NNRA is the sole and the competent authority that has the responsibility for nuclear safety and radiological protection regulation in the country. And for stakeholders in charge of consumer product, NAFDAC is also one of the stakeholders. They take charge. In addition to that, we also have the Center for Energy Research and Training, as well as Nigerian National Institute for Radiation Protection and Research, domiciled with University of Ibadan. YSAT is domiciled with ABU, Ahmadu Bello University Zaria. So they are also designated as laboratories for these purposes. Then for the West African Nuclear and Radiological Monitoring Detection Response Center, I've actually said that. So the plan is to have these monitoring stations at the 6 geopolitical zones. As regard to training program is an ongoing activities. And we've been training, even as it is now, we are training some radiation safety officers at the Institute in Ibadan. But as regard to public health workers, we need to train them, but in collaborations with Ministry of Health, specifically on how to handle radiation injuries as a result of just like I said, the country has signed 2 conventions, aside from numerous other conventions in the areas of nuclear and radiological material. But for emergency convention, we've signed 2 conventions, and we are fully implementing the provisions of these conventions. And there are 6 reference hospitals. These reference hospitals have been designated in case of any accident to be those facilities that will take charge for treatments or providing first aid treatment or first aid management of those that were affected. But to be sincerely speaking, even in the whole world, I think we only have 1 or 2 countries that have specialized hospitals that treat radiation injuries. But as the case may be in Nigeria, these are hospitals that have been designated as indicated in the National Response Plan to give first aid treatment. And if there is need for if there is need for further treatment, because we have signed the Convention on Assistance, as well as Convention on Notification, we notify the international community and they seek assistance to that respect. And as regard to stockpiles of national stockpiles of medications as well as equipment, the hospitals have protocols to deal with such. But a national stockpile is not available. But for each of these reference hospitals, they have protocols to deal with such. So I think with this, I'm not saying I think, but I felt with this, we scored ourselves 4. Then for the second indicator is enabling environment in place for management of radiation and nuclear emergency. But what you need to know here is that both the first indicator and the second indicator, they speak to each other and they are interfacing. So there is an integration. So most of the strengths and the best practices are almost the same thing. But as regards to radiation detection equipment, Nigeria has procured a lot of radiation equipment, ranging from radiation portal monitors at the designated point of entries, as well as RIDs, as well as PRDs. And of recent, the police have also been donated with some radiation detection equipment, the handheld equipment as well as mobile detectors, van. And we are still doing more because our aim is to ensure that most of the first responders have those equipment with them, even though it is not our prime responsibility to procure this equipment to them, because we've given them the training, and the training is an ongoing thing, but they should also make effort. And from our own side, we're also making effort to see how we can also support them with the equipment. Collaboration with NCDs, I've said that. Then one of the challenges is lack of adequate opportunities for capacity building of all stakeholders in emergency response. We've been training them, but we are not satisfied to say that we've trained every first responders. Just like I said, training is an ongoing thing, and we keep doing the trainings. So, and just like I said, challenges depending on how we look at it. So it has not stopped our activity, it has not hampered the Nigerian activity, but just to move forward and to move very fast, we decided to put it as a challenge because challenges are always there. Then the upgrade of the mobile vehicle. We have a mobile vehicle, and it needs to be upgraded. It is doing its functions, but it needs to do more of its functions. And just like I said, the police have been donated with two of these mobile vehicles for radiation monitoring. And based on that, we felt we should score ourselves 4 because from the rationale, there are updated policies. And just like I said, we have policies. We have extant regulations, more than 20, about 26 extant regulations, as well as SOPs and guidelines to guide users of these radioactive sources and nuclear material on how to safe use and safe handling of this material in order not to cause any incidents involving, in order not to have radiation incidents and emergencies. And as regards to the coordinating organization, NEMA is the National Coordinating Organization for all emergencies. And the National NREP, just like I said in the earlier, it has about 40 stakeholders that have different roles and functions to play in case of an emergency. And for the committee, NEMA, NNRA, NIAC, and other relevant agencies serve as the multisectoral coordination mechanism for preparedness and response to radiation emergency. We've been having meetings with these stakeholders from time to time, and exercise and drills have been conducted, but most of the exercises that have been conducted are at the facility level. But a tabletop exercise was also conducted a year ago, and even 6 months ago, we also conducted a tabletop exercise to actually test this national plan. But at the facility level, it is done almost every year for all the facilities in order to check their preparedness to respond to nuclear or radiation emergency, because Nigeria is the largest user of radioactive sources in the whole of the sub-Saharan Africa. And most of these radioactive sources are concentrated in the southern part of the country, where we have most of the oil and gas companies operating. So we ensure that they put the emergency exercise or drills into practice, because any accidents or emergencies without lessons learned is as good as no emergencies. So lessons learned will always improve and gives you areas of weaknesses and strength. And it also gives opportunities for more training. And the document also provides rooms for evaluation, update of the plan. And just like said earlier, the NNR has established links and collaboration with Response Assistance Network in case of any assistance. So these priority actions are the actions we felt will sustain us in that level 4 and also move forward to level 5. The reference hospitals will need to have a collaboration with the Federal Ministry of Health in order to see how this reference hospital will be trained as regard to response to nuclear and radiological safety and security-related emergencies within the 6 geopolitical zones, and making of budgetary provisions for the operationalization of the NREP and collaboration between NNRA and other relevant MDAs, and to also create opportunities for testing relevant policies and plans through simulation exercise in the absence of real nuclear and radiological incidents. These are some of our references. If you go to our website, all these documents are available there free of charge. And these are some of the supporting documents. We have about 28 supporting documents.
Wow.
And why we have as much as this document is because the nuclear industry is one of the sensitive, or is the most sensitive nuclear industries in the world. So nothing is left unturned. I think with this, I want to say thank you very much for listening.
Thank you so very much. Thank you very much, Dr. Jada, for all the great works. Evaluators, over to you, please.
Thank you very much. I noted you have got good plans that you have put up. Okay, I've got some questions that I've got for you. Have you, okay, can you explain on an event of radiation or nuclear that happened in Nigeria and how you managed it, if you have such? Yeah.
Okay, I would prefer to be taking the responses one after the other. How do we manage?
How, okay. My question is, if you have experienced a radiation nuclear event in Nigeria, how did you manage that? Or if you have not yet experienced that, can you tell me on when last did you have your full-scale exercise on nuclear and radiation?
Whether we've had full-scale exercise?
Yes.
No, we've not had full-scale exercise, but there was an exercise that was conducted in collaboration with the Office of the National Security Advisor. I think last 2 years, which cut across chemical, nuclear, and radiological emergency. So NNRA actively participated in that exercise as a full-scale exercise. But we, just like I said, because we've not had real event, the calls for regular exercise is not there, but we've been carrying out tabletop exercises and updating, and if there is need for us to update the national plan, which is the main document that allows stakeholders to speak to each other, that brings stakeholders together, we do update the document. But at facility level, it's every year. So on Friday or Saturday, I will be going for some facilities to actually observe their drills and exercise and advise them appropriately on what to do, should in case there is an emergency.
Okay, thank you. And also, do you monitor consumer products on, for radiation contamination, like foodstuffs or cosmetics? Do you do that? I'm asking for contamination of radioactive particles on foodstuffs and cosmetics.
Yes, I think this was one of the recommendations or the lessons we learned last year when we attended the conference, international conference on safety and security. But as it is, we have the Center for Energy Research and Training, domiciles with the Ahmadu Bello University Zaria. We also have the National Institute for Radiation Protection and Research, domiciles with the University of Ibadan, that have been designated as their roles and responsibility should there be such cases according to the NREP. But we've not had any cases for now. But it has been provided for in our Nuclear Safety and Radiation Protection Act to monitor radioactivity in consumer products.
Okay,
I can't remember the section, but it is there.
All right.
Yeah.
Okay. And also, do you have plans or protocol or regulations or guidelines on orphaned radiation sources? What do you do with radiation sources or radiation items that are no longer wanted or that are not in use? What do you do with those things?
Yes, we have a waste storage facility which is domiciled with the Center for Energy Research and Training, and that's the only research on nuclear reactor we have in this country. So the temporary waste management facility take care of orphan sources as well as legacy source. So we have orphan sources there, we have legacy source there, and there are also some sources in the Ajaokuta Steel Company, about 240 sources. Plans are underway together with the International Atomic Energy Agency to transport them to the temporary storage facility. Because as it is, investigation has been ongoing in order to know who are the original owners of those sources. Though we know that Ajaokuta Steel Company is no longer functioning. So but the responsibility lies with the NNRA. So we have a temporary waste storage facility.
Okay,
yes.
Thank you. You also talked about kind of incapacitation in your stockpiles for radiation countermeasures. Can you explain to me, if you are to, okay, if there is a radiation nuclear emergency here in Nigeria, how are you going to manage that when you don't have stockpiles for radiation? Okay, taking into consideration that you have elevated yourself to level 4 and you don't have stockpiles, how is that going to work?
Yes, as regard to the stockpile of equipment and medicals, we, as at early this year, myself and together with the head of our National Institute of Radiation Protection and Research, we are working on to have a list of all the radiation detectors across the stakeholders, because we want to know whether those radiation detectors are still working or not. If they are not working, we push them for calibration, but we've actually registered some of our capabilities on the Response Assistance Network based on the ones we have information about, but we are making arrangements. I think by now letters have been sent across the stakeholders to give us a list of the detectors they have and the status of those detectors. We are ready to render free services to recalibrate those equipment.
Okay, so that's for the testing equipment. My question is, when you have tested and someone tested positive for radiation exposure, and you are limited on stockpiles to attend to that exposure, that's my question.
No, we don't have a national stockpile for maybe iodine prophylaxis. We don't have, but what we have, most of all the hospitals, they have the protocols for treatment of radiation injuries. And most of all these, most of the radionuclides that are used have short half-life, maybe 7 to 9 days. So most of these sources are not manufactured in Nigeria. These sources are imported into the country. So if there is need, we import those. They import these radiopharmaceuticals into the country for the treatment of radiation injuries. But if it escalates, we've signed the conventions. It's just for us to notify the international community, and countries that are ready or willing to give such assistance will indicate their interest through the platform and render such services.
Thank you. So I would propose that you add that to your priority area for action, that you capacitate your stockpiles for radiation nuclear exposures, countermeasures. May you add that to your priority areas for action, so that you have something in stock for yourselves, for your country, and not to look for source when you encounter.
Yes, but you know, just like I said, it is not possible to have a stockpile of these radiopharmaceuticals because their half-life is just 7 days.
Yes.
So how do you now keep radionuclide that has just a 7 days half-life for when there is an emergency? Because of the half-life, it's just 7 days. Other radioactive sources have like 200, 1 million years half-life. But for the treatment of radiations, the half-life is too short.
Yeah, they've got short life, but we do have some that have got an expansion of life. But I think it's good that you have your stockpiles for those that have got long shelf life. Because when this happens and you're trying to call another country and trying to get resources, that will be a challenge. I'm just proposing.
Yes, and you know, radiation injuries is a gradual damage. It's not an immediate. We have the stochastic effect, we have the deterministic effect. We have a long-term effect and a short-term effect. And the short-term effect is not an immediate effect. It takes time. It takes time to actually manifest within a short period of time, but not within 1, 2, 3, 4, or 5 days.
Yes, I agree.
Yeah.
I agree with you. Okay, I'll hand over to if he has got anything. I also want to throw the debate or the contributions to external evaluators. Do you have any contributions? Okay, any additions? I'll hand over to the moderator.
All right. right, thank you very much, team lead, for this technical area. So we have contributions. Over to you, sir.
Thank you very much, Mr. Mohamed Ali, for the tremendous work you have done over the last 5 years in this technical area. So I think regarding your observation about the need to have that stockpile, and given the limitations he mentioned, can they focus on ensuring that that SOP they have for managing events is explicit and clear regarding evacuation of whoever is affected with radionuclear events to centers that have this expertise? Or on the other way around, ensuring that the resources need to treat them, could be deployed within the required time. I think their SOPs should be explicit with this, and there should be resources kept aside to ensure that we don't have delay in ensuring that whoever is affected get access to this help they need. Thank you.
Yeah, in a very timely manner too. Thank you very much. I think the DG has a comment. Okay, so I think the DG may want to provide some feedback so far before he moves on to other engagement. Yeah, general feedback. When we are done. Okay, so we still have some time. Thank you, DG. All right, so let's get any other comments in the room? Any other feedback? I think we're good. Okay. So back to the external evaluators. We're done with the feedback.
Okay, thank you very much. So on your first indicator, you scored yourself a 4. And level 4 is saying there is systematic information exchange between competent radiological authorities and human health surveillance units about agent radiological events and potential risks that may constitute a public health of international concern. Systematic information exchange. I've got a challenge on that. You did not convince me enough during your presentation that there is that systematic information exchange. I do agree there is a lot of work that you've done for that technical area. But with regards to systematic information exchange, I'm not very sure. So I'm proposing a 3 so that you work on some areas that we have been discussing during our discussion time. And then on the second indicator, you said you are on level 4 and you scored 4. And it's saying functional coordination and communication mechanisms exists between relevant national competent authorities responsible for nuclear regulatory control, CEFET, and relevant sectors. Again, I've got a problem with this score because you have indicated in your challenges, you talked about collaboration inadequate. You also talked about inefficient signage with authorities responsible for activation and authorization of national emergencies. So with that in mind, I'll be more comfortable if we agree that you also go to 3 and work on these critical areas so that when next you are evaluated, it will be automatically to go to 4 or 5. Because if we don't have coordination, these technical areas, these indicators, if you are not coordinating well, if there is no coordination, it's very difficult to achieve the intended dictate, respond, and prevent aspects of the IHR 2. Thank you. I'll hand over to my colleagues.
So you are proposing as team lead for the first indicator of radiation emergencies, a 3. And the Nigerian team is proposing a 4. So I turn to the co-lead. Are you in agreement with the team lead? Then I turn to the team. Are you in agreement with the proposal of the lead and the co-lead of having a 3? I see. And for the lead is proposing a 3. You are in accordance. I'm looking to the team. You are in agreement, so I turn to the Nigerian team. On the first indicator, the external team is proposing a 3 instead of a 4. Can you live with this?
With due respect, we want to insist that we should be on level 4, because as regards to the technical guidelines and SOPs, we have the technical guidelines and SOPs. And just like I rightly said, we have more than 26 regulations, guidance documents, as well as manuals for the safe use and handling of these radioactive sources and nuclear material. We also have the National Response Plan. And just like I said, the National Response Plan is now under review because of the experience from other countries, as well as experience and lessons learned from those documents that were used as the reference document to develop this particular plan. And as regard to risk assessment, we've conducted what is called design-basis threat analysis. And this design-basis threat is a document that can only, it is not on the need to know, on the need to share, but it's a document on the need to know. Now you should know that we have a design-basis threat document that is being reviewed after every 2 years, but it is not a document that will be shared. It's a very high-level document.
Excuse me, I don't want to interrupt you at all, but we are not in the level of discussing anymore. I'm just asking if you agree, and you are disagreeing. So we are agreeing that we are disagreeing on the score. This means a side meeting for you and the external team lead and co-lead on the first indicator. On the second indicator, we are proposing a 3 as well. Are you in agreement with this? And you just have to say yes or no, and then if not, you have already a side event. So are you in agreement or not?
I still want to insist, because if you look at it, in terms of reporting, I said Nigeria have signed 2 conventions as regard to reporting, as well as convention and assistance. And we also have what is called the Unified System of Information Exchange in Incidents and Emergencies, which is fully implemented as a requirement for signing and ratifying these conventions.
So, sorry to interrupt you. Excuse me. I fully recognize that you this score and the why and how to reach consensus. I would invite you and the lead and co-lead of this technical area to go directly into a side event, because you are the final technical area. We want to finalize the whole meeting, but we cannot finalize it. We cannot go to lunch when you are not reaching consensus. So I would kindly invite the 4 of you to go to a side event. We have some other things to discuss. So I would like to thank you very much for your very interesting presentation, for the discussion. I would like to thank the audience. I would like to thank national and external teams. I hope you can reach consensus and come back to the plenary. For now, this technical area is closed, and I hope you can come back soon. This being...
Thank you very much. Thank you very much. Just a few. So if we can, is a comment for them so that before they leave? Okay, so please you can get back to your seats and the side meeting can take over from there. Dr. Ladu, please.
Mr. Moderator, my apologies.
Yes,
there are two technical areas where there wasn't reached consensus. It is immunization and IPC. I heard they reached consensus. So,
this becomes the third one.
Okay.
So we now have 3 technical areas that we are yet to have consensus. But I'm aware that they've had, IPC has met and they've had consensus now. Can I confirm same for immunization? Excellent. So we are going to have, with the permission of the team lead, that we have the Nigeria team and the external evaluators team. But before that, DG needs to take his leave, so he needs to address us before he leaves. DG, sir, we'll be glad to have your closing thoughts. Today being the last day of this first phase of the evaluation. Over to you, sir.
Well, the external evaluators and the co-leads and, of course, our international election observers, distinguished ladies and gentlemen, and, of course, all the various teams represented here and partners. Well, I'm not going to keep you any much longer. I just wanted to thank you for the work that has been done over the last 3 days. Obviously, there's a lot of preparatory work done before, during, and even after the self-evaluation, and that has continued even into this period of external evaluation. Thank you all for your efforts and for your contributions. Thank you for the passionate debates, arguments over whether, the minority, the ruling party won or they scored more votes than the others or not. But at the end of the day, the important thing, again, to remind us is to be fair, to be objective, to leave room for improvement. If you're going to make a case or advocate for more funding or for more interventions, then there must be justification. And I'm not saying that we should be unnecessarily critical, but the only way we can do all of the follow-on actions that we need to do efficiently is to come up with also a very fair scoring that is aligned with the priority areas and subsequent implementation plans. Just a reminder. So I hope that the technical areas that are at the Presidential Election Tribunal trying to find consensus will arrive at consensus in the spirit of what I've just said. All that is left for me again is to thank the team and to thank everybody. And we will see you on Friday for the debriefing. For those who will be hosting our external evaluators and also traveling or moving around, thank you in advance for your work, and to people moving around also, please travel safe. Thank you very much.
Thank you very much, DG, and we'll see definitely again on Friday for the closing ceremonies. So if we have the Nigeria team now, so let's take first the IPC, Infection Prevention and Control theme. Can we quickly have the lead for Nigeria side and the external evaluator to please address us?
You want to go first? Okay, so thank you very much. Good afternoon, everybody. So after careful we agreed to have it as 3. And for 4.2, we also agreed to have that at 2. But for 4.3, which is on safe healthcare environment, we agreed to actually step that to 1. So it's 3, 2, 1 instead of 3, 2 that was earlier suggested. Thank you very much.
Thank you very much. As he has highlighted, we discussed and we saw the documentation for 4.1, which we needed on the strategic plan, the operational plan, the guidelines. So we maintained it at 3. But however, for the last one on the national standards, we realized that there is a gap there, and there will be need for the priority actions for there to be developed in national standards for safe healthcare facilities in collaboration with the other relevant ministries and stakeholders. Thank you.
All right, thank you very much. And that has been endorsed by the team lead. All right. So the last is, for now, is immunization. So let's have the team leads for both sides address the Congress.
Immunization guy. Behind you. Okay. The question had been whether the ability to respond with immunization campaigns existed at national, regional, and local levels. And the discussion went on, and there was a good deal more substance there than I had been aware of. And the result was?
So after careful deliberation and justification of our position, we're able to convince the team to still maintain our position of 2-4-4. Thank you.
2-4-4. Sounds like one nice formation for a team that is about to win the premiership. All right, thank you very much again for that. And Dr. Henk, we are now left with radiation emergency, and we are not sure if that can happen almost immediately.
Mr. Moderator, I would propose to you, because lunch is coming, that we will wait until Friday morning with this consensus in this last technical area. Is that okay for you?
I think it's okay with the Nigerian team. Thank you very much, Dr. Henk. But we will be rounding up shortly, but let's get back to our national observers as we wrap up for this day for their feedback of the proceedings in the last 3 days. Prof.
Yeah, it's been a wonderful 3 days so far, and the third day also looks like the previous ones. We've got teams presenting so well, and the evaluators too also assessing quite well. We found that even after the meeting in the side rooms, there's no cause for appeal. And I hope that the last one will not cause for appeal. And all this is meant to put us on our toes, to know where we have gaps, so that this country can build and improve on what they're doing. So I want to appreciate particularly the external evaluators who show a lot of understanding. There's no bias behind it, and it's very obvious to everyone with the figures that this course that we got eventually were worth it. Thank you very much. And my colleagues, I'm speaking on behalf of my colleagues, that I think it's good to be an observer.
A warm round of applause for everyone. So far, so good. Thank you so very much. The closing thoughts from you, then we have an announcement from the IHR focal point for the country, and then we round up. Your closing thoughts for now.
Thank you so much, Mr. Moderator. Thank you to all of you, dear audience. Thanks on behalf of the external team. I ask you to stand up and to applaud the Nigerian audience. It has been a tough 3 days, but also wonderful 3 days. And we learned so much from you. I'm sure that we as external team learned more from you than you learned from us. But you also learned from yourself, because what we have seen is that there was a lot of interaction between you. And I think that is one of the main secrets of a JEE process. JEE is about coordination. JEE is about multisectorality. And I'm sure, and there you are not unique as Nigeria, I'm sure that during these days, contacts are established between you, and I would really like to say to you, go on with these contacts. It is not going out of the room now and going on into your own silo with your own thing, because One Health, because IHR is about coordination, working together, working over sectors. I would like to thank the observers. I really think that the fact that you have sit here for 3 days, looking carefully at the process, and you as very distinguished Nigerian high officers, that gave trust to all the others, but also trust to us that we are doing a good thing. So I would like to thank you very much for this. I would also like to thank the team of Dr. Ladoun. The preparations you did and the way that we could do all this in 3 days is because you worked so hard for maybe 3 months on this. But above all, I would like to thank you all for your honest exchange of experience, for your transparency, and also for your sportive behavior, because in the end, it was a bit about scores, and it was a bit about should Nigeria get a 3 or should they go back to a 2. In the end, that is a nice game, but that is not the most important part of this. It is about where are your gaps? Where should we put your priority actions? Because we are all working with limited resources. And there is not gold coming from the air, there's only rain coming from the air. So we need to know where to put the limited resources. And that is where I hope that we can be a little bit of assistance. We are not done yet. We have one technical area that needs to reach consensus. We hope they will reach it by Friday. On Friday, we will come back to you with some first thoughts of what we have seen in our field visits. So we will tell this to you. After that, all our technical experts, the technical leads, will explain a little bit to you. They will say, these are the priority actions that we reach consensus on. These are the scores. Then your high-level decision makers will come in, and I will give some general recommendations from the external team. After that, we go back to our home countries. We will write a report. We will send it to you. We will ask kindly to give your final comments. Most of the comments you gave already during the week. And then within 2 weeks, we hope to give the final report to your decision makers, and then it will be put on the WHO website. It's all a transparent process. And we all hope, as external team, but I will say this on Friday again, that this is the second JEE. You are one of the first for the second, that you will also be one of the first for the third JEE, and then we all want to come back. Thank you so much.
Thank you very much, Dr. Henry. Thank you so much. All right, let me now yield the floor to Dr. Yeladu Okuromadi for our address.
It's not an address. Thank you. Just a quick announcement.
and to give an update of what is expected tomorrow. So first of all, I would like to thank everyone for your active participation, for your engagement from day one. Your contribution has actually made this a huge success. A big thank you to you, and a big thank you to the external evaluators for your moderation, to Ank's team. We thank you for being lenient with our team and for reaching consensus timely. For the activity tomorrow, we're proceeding on the state visit. We have about 6 teams going out from this evening. 3 teams, 2 teams will be going to Lagos State this evening, and Lagos State will be visiting the state's public health EOC, will be visiting the biobank, and there is plan to visit a flagship PHC in Lagos State, just to look at the service delivery and the immunization services. And then another team will be visiting the point of entry, that's the international designated POE in Lagos State. We're looking at Apapa and the international airport. Because of traffic, we may not be able to get to Seme. But if that is still feasible, this will be done within 1 day. So we have to quickly come back tomorrow night again to prepare for Friday. There's another team going to Port Harcourt City. They will be looking at the state public health EOC, as well as looking at environmental impact assessment process in Port Harcourt, and also looking at the National Tertiary Health Facility Services for Port Harcourt, where we have 3 teams that will remain here in FCT. We have a team going to Abatel to look at the veterinary proceeding. We have a team going to look at our public health EOC at the national, our ICC Connect Center, as well as look at our event-based surveillance system. And following that, we'll also assess the service delivery within FCT. That hasn't been concluded on which facility. And thirdly, we'll look at our national reference lab, and we'll be visiting the Office of the National Security Advisor for the country, ONSA. So just to give a brief overview, there won't be any meeting here tomorrow. Our next meeting will be on Friday. We'll reconvene here on Friday by 9 a.m. To get the feedback from the site visit, and also to look at different technical areas once again. After that, we'll proceed to closing ceremony, which will start, I think, by 10 a.m. or 11 a.m., depending on how quick we are able to wrap up. So a kind reminder to please remind our different CEOs, MDs, EDs, DGs, PAMSEC as necessary, as much as possible, for them to be here as we unveil the next JE score for the country for the next 5 years. I would also want the head of different partners also to be in attendance. That is also necessary for priority actions as well as for resource mobilization. So on this note, thank you once again, and see you on Friday.
Thank you so very much, Dr. Yeladu Kuromade, for all the great job. So it's like we are done with the first half. Some scores have been made, but we now need the VAR to look closely at those scores when they go to the field. And we're back on Friday to now have the final approved scores of the assessment. But like we've emphasized over and over, not just about the scoring, but it's more or less to identify where are the priority actions we need to focus on moving forward for us as a country. Let me also add quickly that all those who traveled from the states outside Abuja, kindly ensure that you submit your retirement at the registration desk for relevant logistic support moving forward, so that you can get some prayer points in your email later on. All right. So on that note, again, we want to say a very big thank you to everyone. A round of applause for ourselves for this wonderful, wonderful, wonderful engagement. Lunch is served at the usual places we normally take it. Enjoy the rest of the evening. God bless you. God bless Nigeria.